No, Chris.
Ready? Oh. It got really quiet in here, so I guess it's time to start. So we'll call this meeting of the Medical Services Board to order. And Judy, if we could start with roll call, please.
Christy Blakely is excused. Timothy Fox.
I'm on the line.
Patricia Gibbons.
Present.
Brigida Hughes.
Present.
Brenda Lacombe.
Here.
Paul Malinkovich.
Here.
Amanda Moore.
Here.
Ginny Riley.
I'm on the phone.
Donna Roberts.
Present.
Mike Stahl.
Here.
Mary Young.
Here.
We have 10. We have a quorum.
Thank you very much. General announcements, the date and location of the next Medical Services Board meeting. The next meeting is scheduled to be held Friday, February 13th, 2015, beginning at 9 a.m. here at 303 East 17th Avenue, Denver, Colorado, in the 7th floor conference room. It is the policy of this board and the department to remind everyone in attendance that this facility is private property. The capacity of the meeting room is 80. Please do not block the doors and stand around the edges of the room, and please turn cell phones off while in the meeting room as they interfere with the recording equipment. If I could have a motion for the approval of minutes for December 12th meeting.
So moved.
Motion. Any discussion on them?
I'll abstain since I wasn't able.
Thank you. All those in favor of the December 12th minutes, please signify by saying aye.
Aye.
Ms. Riley?
Aye.
Mr. Fox?
Aye.
Very good. Thank you. And moving into the rules, we got a couple emergency rules. So if I could have an emergency adoption motion?
Move that all emergency rules that are adopted include a finding that their immediate adoption is imperatively necessary to comply with state or federal law or federal regulations, or for the preservation of public health, safety, or welfare, and that compliance with CRS 24-4-103 would be contrary to the public interest.
Second.
Got a motion and a second for emergency adoption agenda. All those in favor, signify by saying aye.
Aye.
Ms. Riley?
Aye.
Mr. Fox?
Aye.
Very good. And so we can move into document 1. If I could have a motion for document 1, please.
Move the emergency adoption of document 1, MSB 14-10-17-A, revision to the Medical Assistance Special Financing Division rule concerning the creation of the Colorado Dental Health Care Program for low-income seniors, 10 CCR 2505-10, section 8.960, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
A second, please.
Second.
All right, we got a motion and a second for document 1, and we have Nancy Dolson already up at the table. Welcome.
Good morning. Thank you.
This is Ginny Riley. I just need to say that I operate an agency that includes the Area Agency on Aging.
Thank you, Jenny. Nancy.
Good morning. Thank you, Mr. President. I'm Nancy Dolson. I'm the Special Financing Division Director at the department. And it's my pleasure this morning to bring forward to you this rule to establish a new program at the department, the Colorado Dental Health Care Program for Low-Income Seniors, which will begin July 1st, 2015. It allows us to grant out $3 million in funding to qualified grantees to provide dental services to low-income seniors who do not otherwise have dental coverage available either through Medicaid or Old Age Pension Health and Medical Care Program or private dental insurance. This rule comes about from Senate Bill 14180, which was obviously adopted last session. This reorganizes and relocates a previous dental grant program that's winding down at the Department of Public Health and Environment. And now that we have a dental program for adults, again, this is offering grants for seniors who otherwise don't have dental services available. And just by way of a little more background and a little context as you look at this rule, the qualified grantees under this program are area agencies on aging, community-based foundations or organizations, federally qualified health centers, safety net clinics, or local health districts, local public health agencies, or private dental practices. Qualified grantees, there's a lot of responsibilities that's put on them to outreach and identify eligible seniors, to outreach to qualified dental providers within their area, to maintain records, to either distribute funds to dentists and hygienists to provide services or to provide them directly, and of course to do some reporting to the department. Under the legislation, there was a senior dental advisory committee that was created that began meeting in early September and met every 2 weeks through December to develop the grant application and these rules that you see before you. And these rules were recommended unanimously by that committee for this board. There's a few things in particular that the legislation asks that the rules describe, that we define what an economically disadvantaged senior is. We have a description of covered services, what are co-payments will be required, and if so, the allowed amounts, and a distribution formula for the $3 million across the state. So with that, I'll direct you to the rule.
Ms. Dolson, before you
Yes, sir.
get into the rule, can you explain why this is coming as an emergency rule, please?
Absolutely, you got it. So we want to have the grants up and running on July 1st. So our intention is the rules are adopted today. The grant application will be released on Monday, and we'll give potential applicants a good 30 days to be able to apply. That puts us toward near the mid or end of February when those applications will be due. We'll then need to have a grant review panel, review those and make recommendations to our executive director, and then go through the procurement process to issue purchase orders or to engage in contracts. So kind of that timing to have everything ready by July 1st, that's why the title's coming forward for January. And just to let you know as well, with the primary sponsor of Senate Bill 14180, when we looked at an implementation timeline and talked to him through the stakeholder process and the development of that bill, it was presumed that in order to meet the timeline, we would have to be given emergency rules. To the rule. On page 1 of 4 of the rule, obviously we have several definitions here. I point you to a couple of things. We have on line 14 and 15, the definition of economically disadvantaged, which the Dental Advisory Committee recommends is a person whose income is out of below 250% of the federal poverty level. And we're defining income to not include resources, and we're allowing that it may be self-declared. We want to meet the intent of the legislation, and yet at the same time make the program as least administratively burdensome for the grantees as possible. And Dan is passing around for you now our covered dental services. And you'll see, again, page 1 of 4 of the rule, line 5, where you say that the CDT, or current dental terminology codes, which we will publish on our website. And so you've got these here in front of you. As you look at the definitions as well, you'll see the maximum allowable fee, that is the total between what the department would pay through the grant and the maximum co-payment that can be charged. We leave it up to the grantees whether they're going to charge a co-payment, but we do set this as a ceiling, the maximum payment charge there. And to let you know how we came up with these procedures, first of all, we started with the existing procedure codes under the, what will soon be a former grant program at the Department of Public Health and Environment, and use those procedure codes and those fees that they have. And then the Dental Advisory Committee also wanted to add endodontic or root canal services as well as crowns, so that those full set of services are available. If you were to look at these fees compared to Medicaid fees, on average, this is about 70% higher than the Medicaid fee schedule. And again, we started at the fees that were under the current EPAG grant program. That's how those were set. Any other questions at the moment? 4 of the rule. Again, you define who qualified grantees are in line with the legislation, and then who the providers will be, which are dentists or dental hygienists licensed and in good standing in the state. We can, a provider could apply to be a qualified grantee if they otherwise meet the requirements. Down on line 17 of page 2 of 4, beginning there, we talk about the request for grant proposals that will go through the application process, as we mentioned, that those will be evaluated by a review panel. And we've got some criteria that we have at the bottom of page 2 of 4 of the rule and the top of page 3 of 4. We, with only $3 million for the whole state, we do expect that we may have more applications than we would be able to completely fund. And so we want to have some criteria there for the review panel in terms of they have to make decisions about who should be recommended for funding first, how to go about that. So we note that preference will be given to those proposals that clearly demonstrate the ability to outreach to and identify eligible seniors, collaborate with community-based organizations, serve a greater number of seniors, or serve those who reside in a geographic area designated as a dental health provider shortage area. And then, again, on page 3 or 4 of the rule, beginning on line 3 there, we talk about the distribution of funds. This was something we talked quite a bit about with the Dental Advisory Committee and how we carve up the state of Colorado. There's many ways to do that. And when you're talking about area agencies on aging, federally qualified health centers, their catchment areas sometimes overlap, as well as public health agencies and so forth. So what we are recommending for the distribution of funds is that the review panel consider that, again, in recommending which proposals to fund, and that the distribution of funds should be based on the estimated percentage of eligible seniors in the state by the area agency on aging designations. There's 16 different area agencies on aging in the state. We have estimated those, the number of seniors that are in there, and that'll help give the review panel some guidance. As you can see then on line 6, the grant awards, our executive director will make the final decisions about grant awards. As I mentioned, the qualified grantees have a lot of responsibilities under this program, including identifying seniors and providers, entering into collaborative relationships with community-based organizations, maintaining records, of course, and reporting to the department. In addition, on line 20 there, you see that this is limited in the legislation, that the qualified grantees can have no more than 7% of their grant award for their administrative purposes. And finally, in the rule here, or next finally, on line 23, we begin talking about the invoicing, that we will have a form and schedule as determined by the department for them to be, the grantees to be reported to us and receiving payment from us. We'll need to know at least the number of seniors that have been served and the services provided. And then finally, on page 4 of 4, the legislation does require the grantees to give us an annual report with more detailed information. So that is the entirety of the rule. Have any questions for me?
Questions?
I have a question.
Yes.
When are you anticipating the RFP will be published?
We're hoping on Monday, if the rules are approved today.
Okay.
You had said you've been working with the Dental Advisory Committee on this, and they're unanimously in favor of the rule as written?
That's correct.
Okay, any concerns that they've been bringing up, or everything's been incorporated?
So for the 3 months that we worked with them, I'll just say, as you can imagine, meeting every 2 weeks. It was we had a very dedicated group of folks on the Dental Advisory Committee. No concerns, if you will, with where the final rule ended up. Some of the questions that they wrestled with as we developed the grant application and the rules and review criteria and so forth is, there's a bit of unknown there. This is a population of people that the department are not known to the department because they're not eligible for our programs. So knowing just how many there are, how far the $3 million would go, how to divide it up through the state were some of the questions that they really wrestled with. And so there were several iterations there that we went through. But in the end, indeed, we were able to address those and come up with the right number.
Thank you. Dr. Malinkovich?
Thank you. I think you mentioned that the fee schedule was 70% higher than the Medicaid fee schedule. I'm wondering about the rationale for having such a high rate, given the small amount of funds that that's available for this program.
So thank you, Dr. Malinkovich, and I will say that that's a concern that I think is shared by some of the legal advisory committee as well. The legislation, though, was specific in that we were to use the existing procedure codes and that fee schedule under the outgoing program, if you will, with the Department of Public Health and Environment. And so that's where those fees are. That it'll be something that we will have to monitor in terms of making sure there are not kind of some perverse incentives to be providing services under this program for folks who might otherwise be covered under our dental program for Medicaid or old age pension covered folks. There is some ability, the department will also have to produce an annual report to the legislature on this program, and that may well be one place, depending how things go after the first year, that we may want to recommend. But in the end, to your question, because the legislation is specific, that we start with that fee schedule.
Interesting.
Any other questions from the board? We have one individual signed up for our testimony for document 1, Pat Cook, I think is what the name says. Is that right?
I'm back.
You could come forward and introduce yourself, who you represent, and your position on this rule.
I'm Pat Cook with the Colorado Gerontological Society, and I have a prepared statement from Eileen Dotery that I will read to the board, and then I have a few statements as a citizen and senior of Colorado. First, we want to thank Chairman Stahl and the members of the Medical Service Board. On behalf of the Colorado Gerontological Society, we would like to support the low-income senior dental rule that's being proposed to allow healthcare policy and financing to complete the contraction with agencies to receive winning bids prior to July 1, such as those agencies will be able to serve clients on July 1. After careful review of the rules related to the low-income dental program, we would like to call your attention to the rule that indicates that agencies will be reimbursed based on invoices submitted after the work is completed, much like a contract rather than a grant. Therefore, we would like to request that the agencies who are awarded grants be given an advance that represents 1/12 of the award grant to have working capital, such as that are able to meet expenses while the first invoice is being processed. Given the slow pay rate of healthcare policy and financing, the incentive to bid on this grant is significantly reduced as agencies may have to wait more than 90 days for reimbursement. This extended wait for reimbursement may serve as a disincentive to agencies to consider bidding on the program, as they'll be unable to sustain cash flow that is necessary to operate the program. We anticipate that many dentists will not want to work with the program given the history of the Medicaid expansion for dental services that was implemented and the long waits, as well as the denials that dentists are receiving for care that was demonstrated several weeks ago at a meeting called by the Colorado Dental Society. Lastly, we'd like to call your attention, though not directly related to the rule, a problem with dental services that we have identified recently. Individuals represented at the dentist office who are served based on eligibility for a Medicaid program. When the bill was submitted to DentaQuest, the individual was denied because they were not actually eligible for full Medicaid. They received the Medicare Savings Program, which is paid by Medicaid. These individuals are often known as partial duals, meaning that Medicaid does not pay for all their medical care. Many of these individuals might have been eligible for the low-income senior dental program, but they were not directed to healthcare policy and finance rather than they were directed over to healthcare policy and finance rather than the Department of Health. The coordination between the low-income senior dental program, which primarily serves patients who receive the MSP program, and Medicaid needs to be improved, such as third-party funding pays for services for those who are eligible, and patients are not left with bills they're unable to pay, and dentists are left with unpaid bills because the system doesn't verify correctly and the referrals are not made between the programs to serve the clients. We ask your help to improve this coordination between the two programs that are administrated by HCPF to better meet the dental needs of older adults. And Eileen welcomes any of you guys that would want to call her and have further discussions in her work to call our office, which is 303-333-3482. Now, myself personally, I've been in medical world for over 45 years. Dental has always been a challenge in our older population. As we started to serve our lower income seniors, we've seen some improvements in dental care. We've also seen some improvements in social behavior with our lower income seniors where they're feeling better about themselves. They have teeth, they can eat, they can enjoy their families. So these programs are very important. On the other hand, we take about 30 to 40 calls a week in our office about needing dental help. And the frustration and the anxiety and what they think they should be getting, what they can get, what they can't get, and doing a lot of coaching and education. So we will continue that endeavor. I personally work with these folks heavily. They're important to me because they have many other issues that I'm working on as well. But I think as we continue our movement into showing that Colorado is one of the most progressive states in the union and that we're doing dental work, that we do it mindfully and we do it for the right reason at the right time. And we support our dentists. Dentists are new to this. They're not quite used to dealing with these issues. They're better at children than they are at the senior and older adults. And so these increased fees that we've asked for legislative-wise is because they have more medical conditions. Our dentists have to get up and speed on dealing with these medical conditions. And they have to know what to do and how to do it at the right time. So thank you again for supporting this and getting this moving forward. We look forward to working with the board and with HCPF on making this a very viable and strong program.
Great. Thank you. Questions for Ms. Cook? Ms. Dolson, in the letter she was reading, the difference between grant and fee for service. Can you comment a little bit on that?
Certainly, in one of the challenges with the existing, soon-to-be previous program with DPHE, and in a lot of ways, some issues that I think we're going to wrestle even with the legislation and how it envisions this new program is that in some ways it's got its foot in both places in terms of being a grant and then being very specific though about that we must pay based on procedure and limit admin funds and so forth. So there's not as much flexibility perhaps as you would normally see there. In terms of the comment about being able to pay 1/12 of the grant award up front, I don't know. I do not see that as being an impediment. I think that would be a change the department could make and be able to accommodate. And so I think procedurally, what that would mean. I mean, we could bring that change when the rule comes final next month. We could have that change here, and we could certainly. Reflect that in the application before it's published if the board would like us to do so.
Okay. Is that something that the board would want to see? Dr. Milinkovich?
I guess the question I would have is, to what degree is this an issue? I'm thinking that most organizations that would be applying for these grant funds would have sufficient funding to be able to operate without going both upfront.
The current funders are several of them are very small nonprofit agencies like Senior Mobile Dental. It's very small, and they don't have those deep pockets. They're not part of corporate America. They, definitely, we want to continue those relationships. They've been doing it for a long time, and they do a great job, and we don't want to lose that service group. And that's why we've come to the board and asked for this special accommodation to make sure that we maintain those relationships with the dentists that have been supporting this program for well over 10 or 15 years.
I think over the next month that the department would just kind of maybe look at some of those providers and I think really see how significant an issue that is before making those changes. And then we'd be open for that change.
Yeah, I don't see any drawbacks unless the department does. And if it creates goodwill and improves access for the elderly population. That seems to make a lot of sense.
And I totally agree. I think we don't want to eliminate some of those important groups from applying because there's that limitation of not having the deep pockets and continuing to try to help.
Yeah.
So, totally agree.
Thank you very much.
Thank you.
Nobody else signed up for public testimony, is there? Would somebody like to? If I could have you go ahead and sign up, and you can sit down, introduce yourself, who you represent, and your position on this rule, and then you can fill it out.
Perfect. I apologize. I'm Jennifer Goodrum with the Colorado Dental Association. I ran into a few traffic issues, so wasn't able to sign up before we got to it this morning. But I did actually, I don't need to belabor, I mean, you've heard very well already from Nancy, and we've been part of the committee process and providing input. But I did hear a couple questions come up that I would like to address if I could. And specifically to Dr. Malinkovich's question about why are the rates 70% higher. I think that actually speaks to how low Medicaid's rates are for dentists right now. And so just because they're 70% higher than Medicaid, they're not actually even at market in this program. So they're still below market rates. It's no huge incentive to a dentist. They're not making a windfall off of this program in order to participate, just because, I mean, I know that seems like, oh my gosh, 70% higher, but Medicaid rates in the state right now are below 50% of market rates. And, you know, dentist costs are far higher than that. And so, I mean, that's something we're certainly looking at addressing Medicaid rates in the long term. How do we make these programs sustainable? But just because I know that that number sounds huge, but just wanted to put that one out there. You know, they are much closer to like CHIP rates, and CHIP's another program that's run by the department. And so when they're 70% higher, they're pretty closely in line with CHIP at this point. So that was one. And then I did hear kind of a comment that, you know, I think there's a little bit of confusion. Just because this program is going to be run through the department, it is not run through DentaQuest, and it's not run through the same system that Medicaid. And, you know, I think there have been some bumps in launching that system. And actually, I mean, it's been, I think, a challenge for us in watching this program kind of come together as the Dental Association, just to kind of wrap our heads around how it's actually going to come together, how these grants are going to work. Are dentists going to participate? Is it going to be something that's easy for them to participate in? Or, you know, I mean, there's so many programs that are brand new and the dental community is trying to wrap their arms around. And so, I mean, I think, you know, we've expressed some concerns to the committee around, you know, how does this all play out? But I think we're at a point right now of just watching, you know, let's let it roll out, let's see how it works, and then if we need to, we can come back and make some tweaks to make sure we've got the participation we need. So, I mean, unless there are further questions, I just wanted to address those two particular points from the perspective of the Dental Association.
Thank you. Any questions from the board?
Okay, thank you very much.
Thank you very much. Okay, we do have a motion and a second for initial emergency adoption of document 1. All those in favor of document 1, please signify by saying aye.
Aye.
Ms. Riley?
Aye.
Mr. Fox?
Aye.
All right, we've got initial approval. Thank you very much.
Thank you, Mr. President.
Appreciate that. Moving on to document 2, also under the emergency agenda. If I could have a motion.
I move the emergency adoption of document 02 MSB 14-11-04-A, revision to the Medical Assistance Special Financing Division rule concerning hospital provider fees collection and disbursement, section 8.2000, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Thank you. Got a motion and a second. And we have Matt Haynes here to present. Welcome.
Thank you, Mr. President, board members. Good morning. My name is Matt Haynes. I'm the Provider Fee Financing Unit Supervisor. I'll be presenting 14-11-04A, which is making changes to the hospital provider fee program. At the October 28, 2014 Oversight and Advisory Board meeting, the Oversight and Advisory Board did vote unanimously to approve the proposed fee and payment methodologies that I'm bringing here today for the model year beginning October 1st, 2014 through September 30th, 2015. In addition to that, the Colorado Hospital Association also gave public testimony at that meeting in support of these changes as well. These proposed rules update the hospital provider fee and payment calculations in accordance with those recommendations from the Oversight and Advisory Board. The proposed rule revisions make changes to the fee and payment calculations and will allow the department to collect sufficient fees from hospitals to fund the health coverage expansions and hospital payments to comply with state statute and the Medicaid state plan agreement with the Centers for Medicare and Medicaid Services, and to cover the department's administrative cost. The major change you're going to see in the proposed rule eliminates the supplemental payments found at 8.2004.c through 8.2004.m. They're being replaced by supplemental payments now found at 2004.c through e. The department is making these changes to streamline the program and make it less complex. This will make the program easier for providers and stakeholders to understand and will simplify the state plan and rulemaking process. Most importantly, this effort is to make it clear how the program is tied to the intent of the legislation. The legislation specifically calls for increasing Medicaid reimbursement, increasing reimbursement for the uninsured, and to implement quality incentive payments, where before we were accomplishing that through what was a myriad of 13 different supplemental payments. It wasn't, we've really streamlined that down where we have a payment now that's based on the inpatient base rate. We have a payment that's focused on uninsured cost. We have a disproportionate share hospital payment. And then we have the outpatient payment, which is also a Medicaid-based payment. And then the hospital quality incentive payment. I want to make it very clear that even though the number of payments have been reduced, the total payments have not been reduced with this program. This is a restructuring of the program, not a reduction. Actually, we are increasing fees this year, and the total amount of payments will increase. I'm happy to go through the rule, but I'll open to any questions you may have. I know that we don't necessarily want to always go through line by line with everything that's there.
Any general questions from the board at this point? Otherwise, maybe just hit on the high parts of the changes of the rule.
Sure.
That you have in there.
Absolutely. My pleasure. In the definition section at 82001, we've had some cleanup, but there is one added definition. And I'll direct your attention, see if I can make sure I pull it on page 3 of 14 of the actual rule document, line 32 and 33, we have added a definition for uninsured costs since we now have payments that are calculated based on that. To the major rule changes you will see, as I mentioned before, at 8.2004.c, is when you begin to see the red line strike-throughs of the payments that were there before. This was the CICP disproportionate share hospital payment, the uninsured disproportionate share hospital payment, the CICP supplemental Medicaid payment. We've added now the inpatient hospital base rate supplemental payment has been moved to C. Now the DSH payment is just the disproportionate share hospital payment. There's no distinction between the uninsured and the CICP payment now. It's one DSH payment. And that's now at D. And then at E is where we have the uncompensated care hospital supplemental Medicaid payment, and that's the payment. I apologize if I'm not speaking loud enough. At E is the uncompensated care hospital supplemental Medicaid payment. That's the payment that is now focused on uninsured. Additional red lines you will see continuing there through M are all the other supplemental payments that were in existence that we've now eliminated from the program and will no longer be making. And now found at F is the hospital quality incentive payment. There is some change to the hospital quality incentive payment for the model year beginning October 1st, 2014. The CLAPC measure has now been moved to just a reporting that we will keep track as a department, but in terms of payment, that is no longer a measure. That measure has been replaced with an emergency room measure that's now the rate of non-emergency room visits. There have also been some additional changes with the hospital quality incentive payment. Previously, providers that did not qualify for every base measure had payments reduced. Now everyone needs to have 5 measures, and in order to accommodate that, we have 5 base measures, and the program has added optional measures so that all providers participating can have some way of making sure that they participate in 5 measures. Those are the major changes that we did have in rule, but I'll be happy to address any particular questions you may have.
Questions from anyone? Ms. Roberts?
I just have a comment. I appreciate as a frontier dweller, I appreciate the fact that you look at the economies of scale to the essential critical access hospitals of rural Colorado. Thank you from all of us that represent rural America.
I just have a question regarding the emergency departments. What are the criteria again? I'm sorry, I'm not able to see that. You said something about low acuity visits?
For the non-emergent ED measure?
Yes. And I guess the reason I'm asking that question is how does that reconcile with the EMTALA? You know,
I'm not sure about the second half of your question.
well, in regards to patients that present to an ED, they're required to have medical screening. So if they're rated as a low acuity and that's a criteria for making that judgment, how do we reconcile that?
You know, I'm not sure right now exactly.
Okay, I think
we'll
that's an
talk with the committee and
important
get
issue
back to that.
because all emergency departments are required to medically screen anyone who presents, and so they would be penalized for those low acuity patients that show up in their emergency department and they don't have any control over that. So
Sure, and I think an important piece with that particular measure is that this is a process measure on the ED
Yeah.
as opposed to an outcomes
Sure,
payment.
yeah.
So with that measure, it's really, are they getting information about their local PCP clinics
Mhm.
and the doctors to medicate patients? So is the emergency room seeing these incidents that are happening and then providing that information? Are they providing information about Medicaid or the nurse advice lines?
Okay.
Are they notifying the RICO of the ED visit,
Okay.
the Regional Care Collaborative Organization? Do they have policy and guidelines enforced for no replacement
Okay.
prescriptions for opioids lost or stolen or destroyed? Do they have policy or guidelines for no long-acting opioids are prescribed? So it's more of a process measure than
Okay.
an outcomes measure, so that may address that.
Okay, I just want to be sure that we're not using the measure of low acuity patients as the incentive or disincentive, whichever the case may be. So if it's process and it's the organization can demonstrate they're doing all those things, that's great.
Great, yeah, and that is
Okay.
my understanding.
Okay.
It's certainly a process measure.
Okay.
Thank you for your question.
That can be confirmed by next month, though?
That would be helpful.
Certainly.
Yeah.
Great. Dr. Malkovich?
Yeah, I actually had the same question. What can you do if somebody shows up?
Yeah.
So it would be nice to see, maybe in writing, what all of the measures are, all of the quality measures are.
That would be
and how-
helpful.
And how they're measured.
Certainly.
If you could just get that information. The other question I had is, my assumption is that all the participating hospitals are supporting the changes in this.
Correct, and there was a subcommittee that was developed in the development of these measures.
Not just the measures, but the entire rule.
Yes, yes.
The one question that I have is looking through here, how's psychiatric hospitals handled? I see it's excluded multiple places. Are they included anywhere in the rule?
In the hospital provider fee program, they are excluded from fee as well as payments.
Completely. And what's the rationale for that?
Predominantly, those are handled through the managed care and the BHO contracts, and it's a separate payment and structure.
Okay.
And that was through a pretty lengthy stakeholder process when the program was developed originally.
Great, thank you. Other questions from the board? We haven't had anyone sign up for public testimony on document 2. Is there anyone here who would like to sign up for document 2? And seeing none, if there's no more questions or comments from the board, I'd call the vote on initial approval for document 2. All those in favor signify by saying aye.
Aye.
Ms. Riley?
Aye.
Mr. Fox?
Aye.
All right, we've got initial approval document 2. Thank you very much.
Thank you.
Going into consent, the final permanent adoption with the consent agenda. If I could have a motion.
I move the final permanent adoption by consent of document 3, MSB 14-31-8, revision to the medical assistance eligibility rule concerning the rule citation correction in section 8.100.7.B.1.C and 8.10017 point B, point 2, point C, and document 4, MSB 14-07-28-A, revision to the Medical Assistance Health Programs Benefit and Operations Physician Services Rule concerning podiatry services, Section 8.200.3.A.8, in parentheses 8.200.3.d, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion, second. Thank you very much on that. All those in favor of the consent agenda, please signify by saying aye.
Aye.
Ms. Riley?
Aye.
Mr. Fox?
Aye.
Very good. We have approval of the consent agenda. Thank you very much. Moving into the final permanent adoption part of the agenda, we need a motion for document 5.
I move the final permanent adoption of document 05 MSB 14-10-28A, revision to the medical assistance eligibility rule concerning allowance deduction section 8.100.4.c.1.d, incorporating the statement of basis and purpose of the statutory authority contained in the records.
Second.
Got a motion and second for document 5. Thank you. And we have Maribel Guadarrama and Ana Bordola. Welcome.
Happy Friday.
Good morning, Mr. President and board members. Thank you for your time. My name is Ana Bordayo. I am the Child Health Plan Policy Specialist. And with me today, I have Maribel Guadarrama with our Eligibility Policy Manager. Today, we are here today to present the rule concerning allowable deductions to calculate the modified adjusted gross income for our MAGI medical assistance programs. The current changes bring the state rules in compliance with the federal rules and identify the allowable deductions as defined under the Internal Revenue Code Title 26 USC Section 62 to get the modified adjusted gross income required to determine the eligibility for MAGI medical assistance programs. At our last meeting, Ms. Prey was concerned about how the department had written the rule. She felt that we should either provide a complete list of allowable deductions or just reference the IRS citation. After further consideration and research on how the department should write the rule, the decision was made that it would benefit our clients and stakeholders to list most of the common allowable deductions used to determine the modified adjusted gross income instead of just referencing the IRS citation. If we were to just reference the IRS citation, we believe it would cause confusion. Also, the IRS citation incorporates a significant amount of information to sort through, and this can be difficult to understand. Other eligibility rules provide lists which have found to be very effective and easy to understand for our clients and stakeholders. The department has also decided not to provide a complete list of allowable deductions since some have already sunsetted and could possibly sunset in the future. We have added 2 additional deductions to the list. We reviewed the Internal Revenue Code Title 26 USC Section 62 to make sure we included the most important deductions, and also compared this section of the tax code to the 1040 tax form to ensure that we didn't miss any of the common allowable deductions. We feel confident that the rule is written in a manner that the clients and stakeholders will be able to easily comprehend. We felt that providing a list of the most common allowable deductions to calculate the adjusted gross income will be more suitable for our applicants, eligibility workers, and stakeholders. But most importantly, the updates
to this rule ensure that the department is in compliance with the federal regulations. We would also like to thank the Colorado Center on Law and Policy who provided us feedback on this policy. Are there any questions on this rule?
Yes, Mr. Coleman.
I can't remember from the last meeting if I even asked this question or if it even popped into my head. So how is this, the allowable deductions now, how are we looking at that with the 5% disregard? Is this in addition to the 5% disregard, or are we using these deductions instead of the 5% disregard?
They're actually two completely different things. The 5% disregard is only applied to those who are not eligible.
Correct.
But it's completely separate.
Okay, so I guess my concern is then, how are we communicating this process to eligibility workers?
And if I may, so this is Maribel Guadarrama. So in essence, what Anna's saying is that the 5% is in addition to the disregards, but the disregards are something that apply to any client that is applying for medical assistance. So if they have any deductions, we have added on the application and the online and paper application. So we, as far as the 5% disregard, that was a rule that we just recently brought, and we have a communication out there of frequently asked questions document that explains that the 5% is only applied if someone's not going to be eligible for Medicaid. It's an extra step to see if we can still make them eligible, specifically for those that are at the top end of the income threshold. So there has been communication out there as far as through training when we implemented some of these deductions, as well as training for the 5% and a frequently asked document that we have out there as well.
Okay, so let me make sure I understand this. So once a person applies, they apply these deductions, and then if for some reason they're still a little bit high, then you apply the 5% disregard?
Right. So if their income, let's say for example, our Magi adult population, the FPL limit is 133% FPL. So after they provide us their income and they say, I have student loan interest, that's one of the deductions, their income ends up being at 136% FPL. In that instance, then we would apply the 5% disregard, which would then make them eligible. If they were 143%, even with applying, we would still apply the 5%, but that would still bring them down to 138. Is my math correct? So they would still not be eligible, but we would have applied that 5% in addition to the deduction that we've already taken for them.
And that's just what I wanted to clarify. I want to make sure that we're clear that the 5% disregard will apply after these deductions have been made.
No, and I appreciate that. It is after the deductions.
Ms. Roberts?
Thank you, Mr. President. Does the individual have to contact the department to ask for this 5%, or is this an automatic internal review and correction?
Thank you for the question, Ms. Robert. This is Anna. The 5% disregard is automatically applied systematically.
Other questions from the board? I guess my question would be, and I understand the rationale of kind of not putting the complete IRS rules in here and listing the most common ones. What I'm wondering though, should we put some language in there that says these are the most common ones? That it's not an entire list, to again simplify it and to make sure it's very clear to the person reading it. These are the most common ones. There could be some exceptions. If you want to go to this IRS code, you can. Could we put a little language in there? I mean, it's one or two words I'm thinking.
No, I appreciate that.
This is Jenny Riley.
Yes, Ms. Riley.
I don't know that you could do that because of the CBMS programming. I mean, this is what CBMS is going to be programmed to do, right? This list?
Good question. Ms. Gibbons?
So on line 5 and 6, with the language but not limited to open that door, that implies to me that this list is
Which
on the Magi
lines?
methodology for income calculation, page 1 of 3, line 5 and 6. they're in brackets, but it says there's a list here of
Right,
including
and
these
I was
items.
looking down more on the
Oh.
the allowable deductions
Allowable.
on line 14 of
Oh, I'm sorry.
2 of 3.
So could we put similar language in then, maybe?
Could be. Ms. Riley, explain your question again.
So it says in the materials that there's going to be a change in CBMS to allow these deductions, because right now it's not. And so if these are the deductions that are going to be programmed into CBMS to allow, how do other less common opportunities for deductions happen?
Good question.
So, thank you. So, good question. So, let me make sure hopefully I'll be able to answer everything because it all ties in very well. So, so definitely we can add more additional language to make it a little bit clearer that these are not these are the most common deductions and it's not all inclusive. And in full transparency, we also got feedback from CCLP on the same thing, except the feedback we got is so late and. I'll be honest, we got here so late because of the traffic and everything that we weren't able to make changes this morning. So if the board would like for us to take that back and make those changes before approving this rule, we'll definitely take that into consideration. We can definitely do that. As far as addressing the deductions within CBMS, so the common deductions are either have been programmed or are scheduled to be programmed into CBMS now. For those less common deductions, the ones that are less common are those that, based on our research from other states and kind of some discussions with our legal department and others, that we don't believe Medicaid clients will have those come up. However, like for example, there's one that's deforestation. I'm just throwing that out there. I saw some reaction from some of you when I said that is not very common for that to come up, but that is something that's listed in the IRS citation. So in the instance that if something does come up that we do not have CBMS program for and we haven't accounted for, at that point, then definitely we can work with the client to see how we can apply it with their Medicaid account using some of our profiles at the state level to help the client get the eligibility that they deserve. And we can also at that point evaluate if we need to include that deduction into CBMS and also make modifications to the rule to include something that we didn't think was so common that all of a sudden came up. So it's kind of our balance, our compromise. One of the struggles that we've had, and again in full transparency, is the MAGI Medicaid rules are referring us to IRS citations, and none of us are IRS tax specialists. So it's a fine balance that we're trying to work right now, and also working with Centers for Medicare and Medicaid. They've also taken the approach of taking the most common as well versus trying to refer to all the citations, all the deductions for IRS.
Okay. Does that help, Ms. Riley?
Yes, it does.
Okay. Dr. Mikovich?
Thank you. I mean, just to follow up on your comments, it seems to me that one could simply put in here something like the following most commonly allowed deductions.
Right. Right.
I think that would satisfy your concern.
That would satisfy my concern.
Yeah, we agree.
Can we, without an R page, make a simple adjustment like that and still do
Yes.
final
Yeah.
approval? Okay. All right. So looking at, I think your suggestion is on page 2 of 3 on line 22.
That's correct.
Instead of following deductions, we could change that to following most common deductions. I'm not very good at words, so that could be something we talk about. We do have one individual signed up for public testimony, so before we get too far into that, I'd like to hear from Bethany Prey, who signed up. If you come forward and who you represent and your position on this rule.
Thank you. I'm Bethany Prey with CCLP, and I appreciate the opportunity to talk and the opportunity to have spoken with Ms. Bordallo and Jeff Oliver actually just yesterday, and I do appreciate that was, my comments were exactly what has been discussed here today, that there needs to be some language that indicates that the list is not exhaustive, so that people know that if there's something else, I mean, not all of them are quite as uncommon as the forestation or deforestation sort of thing. Losses from property, for example. So I do think it's important that people know that they can go beyond that list, and they may need to speak with their worker or figure out another way around the limitations. And I understand, too, that CBMS can't have endless adjustments, so that's understandable.
With that simple change that we're talking about, would that work?
The suggestion was the most common deduction, the following are the most common deductions?
Yes.
I guess I would want to make sure that it was, I don't know if this needs to be quite this explicit, but that most but not all of, in some way indicate that, make it crystal clear that there are other ones out there that one may want to look into. So I actually don't have it in front of me at the moment. I
guess that's what I was getting at, if we could add the language, but not limited to just this list. But these are the most common, but similar kind of language. I'm sorry, I wasn't clear.
Okay, so we need to get the exact language down. Where, Ms. Gibbons, if you'd like to try on line 22.
Okay.
I think we should use the exact same language that you referenced earlier from 1A.
Yeah.
And just repeat it again so that we're consistent with the language throughout the document.
Yeah.
I think that would be an okay.
Yeah, that's what I was trying to
Including but not
recommend.
limited to.
Yes.
Because
Okay.
they want that very nice answer,
Yeah.
and then we just slide it in. And
Exactly.
So we'd say the following deductions are allowed but not limited to, are included,
Including,
but not limited to.
limited to the following items, colon.
Yeah. Thank you.
Everyone okay with that?
And I would support that as well.
Okay.
Right, and there are other issues around the rule that I would like to discuss further, and I will arrange that with the department.
Okay.
All right, thank you.
At a later time then?
Yes.
Okay.
Thank you very much.
Very good. Thank you. Would anyone else like to sign up for public testimony on document 5 that didn't get a chance to? All right. Any other questions or comments from the board? Otherwise, with the slight modification to line 22, all those in favor of document, what are we on? Document 5, please signify by saying aye.
Aye.
Ms. Riley?
Aye.
Mr. Fox?
Aye.
Great, thank you. We have final permanent adoption of document 5. Thank you very much. Appreciate it. Moving on to document 6. If I could have a motion?
I move the final permanent adoption of document 6, MSC 14-07-15-B, revision to medical assistance, community living benefit rule concerning in-home support services, section 8.552, incorporating the statement of basis and purpose and specific statutory authority contained in the reference.
Second.
Got a motion and a second for document 6, and we have Candy Dalton here. Welcome.
Good morning, Mr. President, members of the board. My name is Candy Dalton, and I'm the Participant-Directed Program Specialist for Long-Term Services and Supports. So I'm bringing this rule back. We presented it last month. It's making changes to our in-home support services, which is one of our consumer-directed options. And these changes are primarily based on a bill that was passed last session. Since the last reading, we made a couple changes to the bill. The first is based on stakeholder feedback that we change nurse oversight to oversight by a health professional. So we did make that change. And then the second change was making some adjustments to our definition for health maintenance activities. We worked with stakeholders and the Colorado Department of Public Health and Environment to just clarify the language that was in there a little bit, to articulate that if the client's condition gets worse or any new symptoms appear, that in consultation with the client, the physician would be contacted, and then that would be documented. And what that does is ensure that the client is getting appropriate care while still maintaining the integrity of consumer direction.
Okay. Both those changes are on the R page that has been handed out in front of
Correct.
us? Okay,
Yes.
so I'd like the board to look at the R page for document 6.
So the health maintenance definition change is lines 18 through 21. And then the healthcare professional change is 35 and 36.
So with those, if people have had a chance to kind of read through those, we need to approve the R page. So I'd look for a motion of approval for R1 for document 6.
I move approval R1 for document 6.
Second.
Got a motion and a second for the R page. All those in favor, signify by saying aye.
Aye.
Aye. Ms. Riley?
Aye.
Mr. Fox?
Aye.
All right, we have approval for the R page. Okay, would you like to go through the rest of the rule, kind of remind us where we're at? And
The only other change we made to the remainder of the rule was just to make sure that we had left out a rule that's saying the authorized representative cannot be reimbursed for the provision of IHSS, and that's to align it with the bill that was passed. The rest of the bill includes the following changes to align with the bill, and it's not any changes. There are no changes from the previous month, but it allows IHSS to be provided in the community. That the client gets to determine the amount of health professional oversight. We removed the 444-hour per year limit for personal care. We specified that IHSS can be provided under the spinal cord injury waiver, and we strengthened the language to ensure that we emphasize that it is a consumer-directed program. So even though there is some oversight by the health department, the client is ultimately responsible for managing and supervising and training their attendants.
questions from the board on document 6? Let's see if anyone signed up for public testimony. Okay. We do have one individual signed up for public testimony in document 6, David Bolin. If you could please come forward and introduce yourself, who you represent in your position on this rule.
Mr. President, members of the board, my name is David Bolin. I am the CEO of Accent on Independence. We're the first IHSS agency in the state, and it is the biggest part of our business. I was also the person that instigated both bills that implemented IHSS. Want to thank the department. Now, we support the changes that have been made. The R1 page that you just approved included all of the changes that we wanted to see, because there were just a few pieces where the Department of Public Health and Environment seemed to want to take away the principal person in this program, which is the consumer who knows their care better than all of us. And so we wanted to make sure that the consumer always would direct. And I have to say that the Department of Healthcare Policy and Financing advocated very strongly with us, with the Department of Public Health and Environment, and I really appreciate their commitment to consumer-directed programs.
Great.
Thank you.
Thank you very much for your commitment to this and your tenacity to stay on it. Questions for Mr. Bolin? Or anything for Ms. Dalton? Great, thank you very much. We do have a motion and a second for final approval, permanent adoption of document 6. All those in favor signify by saying aye.
Aye.
Aye. Ms. Riley?
Aye.
Mr. Fox?
Aye.
Very good. We have permanent adoption of document 6. Thank you very much.
Thank you.
Moving on to a rule that we tabled back in August, I believe, after initial approval in July. We have document 7. If I could have a motion.
Move the document 7, MSB 14-05-08-A, revision to the medical assistance rule concerning early and periodic screening, diagnostic and treatment, EPSTD in parentheses, personal care, section Section 8.535 be removed from the table for consideration for final permanent adoption, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Do I have a second?
Second.
Thank you. So we have a motion and a second for document 7, and we have Valerie Baker Easley here.
That's right.
Good luck on this one.
Thank you. That's appreciated. So, Mr. President, members of the board, I am here to present the personal care rule, which is back before you again. It was last here at this table in July. And what I would like to do in this presentation, because we're going to cover a fair amount of material, is to break it into 2 sections. The first one will be to provide some background information on what's been occurring in the past 6 months. I'm sure you'll all remember that when we were here in July, there were many questions, many concerns. The rule was still pretty freshly minted at that time, and so a great deal of work has been done on it in the meantime. And as the first part of our discussion about that, what I'd like to do is walk you through this handout that Dan's just passed around that will summarize that information. And then as the second part of my presentation, before we go to questions and testimony, I will walk through the changes to the rules specifically.
Okay, thank you.
So if we can turn to the handout or anything before we move forward. And I believe that the board members on the phone have an electronic copy of this, so I'll note the slide numbers as we go through. There are 3 sections to this presentation, and they will include policy suggestions that were made to this rule that were adopted by the department based on discussions with stakeholders, providers, clients, and concerns raised at this board meeting. The second section will be policy sections that were not adopted, and I'll share with you the rationale for those. And the third section will be recent developments regarding the benefit that I think it's important you should know about as you consider the rule. So let's move on to slide number 3, which begins the policy suggestions that were adopted by the department. The first one is that we reduced the number of personal care tasks needed to qualify for the benefit. Originally, we had set that number at 4, which is consistent with other states that provide a similar benefit. But after involved discussion with many stakeholders, providers, clients, family members, we did determine that it made sense to lower that to 3. So that's where it now stands. We did add 2 more tasks to the tasks that qualify as personal care services. There were a total of 16 when the rule came to you in May, and we added 2 more, so there are now a total of 18. You will see the 18 listed out for ease of reference. They're there for you on slide number 4.
Which were the 2 that you
Yeah,
added?
sorry, the 2 that were added were meal preparation and the provision of medication reminders to the client. And we did seek guidance from our federal partners as we looked at adding these 2 tasks into the list, and we do have their support to do this. So moving on to slide number 5, this continues our policy suggestions that were adopted. Class A and Class B agencies are now noted in the rule as providers of this benefit. It was Class B agencies when it came in May, and it is now both because Class A agencies can provide personal care services as well if they wish to do so. Any agency does need to be in good standing and needs to meet CDPHE's home care rule certification requirements in order to provide this service. Our next change is that we did adopt the suggestion that we were referencing the services for personal care as non-medical services, and that was not a popular term, I guess I can say. It was just not considered to be the best term that could be used. So we did accept the suggestion to change that, and we renamed that as personal care services, which I think is more descriptive anyway. Moving on to slide 6, with policy suggestions that were adopted, the department was requested and did, I think this was a great suggestion. We reviewed this rule with the home and community staff from CDPHE, which has similar and related regulations in their own rules. And so we went through this line by line on a Friday morning recently and made sure that there was no conflict at all in the language for the regulations regarding the providers or clients. So the two documents are in alignment, which I know is part of the government's SMART initiative and was an appropriate thing to do. Moving on to our next slide, slide 7, continuing the policy suggestions that the department did adopt. We clarified the indication in the rule that clients may exceed frequency definitions that are set forth in the usual frequency of the task. So this was one of the points that was brought up at the previous meeting. The way it was worded sounded as though, for example, if the rule allowed three baths per day as the average that a child would need, and a particular child happens to need 6, this clarifies that that child can receive the number of services they need. It does note that agencies need to be prepared to provide documentation that tells us why this number of baths or whatever the service might be are needed, so that we know it really is appropriate. But given that, this wording has been changed, as you see. Moving on, we clarified the definition of behavioral intervention, which I think was incomplete at the time that it was brought to you in the first rule. And what we changed was we expanded it to include that extra time may be needed for this type of activity. And then we also removed some examples that were found to be confusing to stakeholders. It sounded as though we were limiting this activity to only those particular diagnoses. So we pulled that because it was confusing people. Moving on to slide 8, continuing with policy suggestions that were adopted. The meaning of queuing was expanded, and this was one of the questions that was raised at MSB in July also. So it's now defined as providing a prompt or direction to assist the client in performing an activity that they're physically capable of performing, but that they need help to independently initiate. The last policy suggestion that we adopted and I want to share with you today is that we removed references to CNA licensure and the training requirements in personal care policies. So this is an example that I'll speak to this a little bit more in the changes that were made to the actual rule language. But where we had, for example, a whole list of qualifications that are really CDPHE's qualifications and not HIPPUF's, we replaced that page and a half of listing with the citation to the CDPHE regulation. And that way, if it changes in their rule, our citation remains correct, and we don't find that our rule is lagging behind in accuracy. So that is the end of slide 8 and completes the policy suggestions that were adopted. Now I want to go into the policy suggestions that were not adopted. So those begin on slide 10. The first suggestion was that clients need total to moderate assistance in only one of the 18 personal care activities, and we did not adopt that. After careful review and again working with our federal partners, CMS, on guidance, 3 is the number that we feel is most appropriate for this benefit. And quite honestly, it's hard to qualify for fewer than 3 when you go through and look at the tasks, because so many of them dovetail with other tasks. Moving on, policy and suggestions not adopted. It was suggested that we allow for the provision of protective oversight as a standalone reason for personal care. So not in context with any other personal care tasks. And we did not adopt that. It was suggested as well that we include homemaker services and exercise, which include range of motion, as personal care tasks. And these were not included. The other 2 that we talked about earlier, medication reminders and meal preparation, were included. But again, in our conversations with CMS, This would duplicate services that are offered in the waivers currently. And we are federally prohibited from duplicating waiver services. So these two were not included. Moving on to slide 11. This one. Two final policy suggestions that were not adopted. The first is the inclusion of schools as an eligible place of service within this benefit. And that was not included because personal care is already offered in schools through the Medicaid School Health Services for Kids program, and that's through children's individual educational plans. So again, we come up against the waiver duplication of services that CMS screens us very carefully for. The final policy suggestion not adopted, and this was certainly a very important one to our stakeholders. So I do want to call attention to it. This was raised in the meeting in July, and that was the inclusion of parents as a provider, an eligible provider type for personal care services, and that is it's federally prohibited by our federal partners. So that is simply something it's not in our purview to change or to do. So that concludes the policy suggestions not adopted. I really wanted to go through these so that the board understands the conversations that happened behind these issues and the decisions that were made and what the department's rationale was behind not adopting these.
One quick question on that before we jump in. You talk about the eligibility. I'm looking at services in schools.
Yes.
And the benefit coverage through Medicaid that's already there. They, through that program, they would do all 18 of these personal care tasks?
They would cover whichever of the personal tasks are listed out as part of their IEP and that are appropriately performed in the school setting.
Okay. All right. Thank you.
So let's move on to slide 13. The last two slides are related developments that have occurred regarding this benefit, and I think it's important.
Let's hold on quickly, Dr. Milinkovich.
Oh, sorry.
Sorry, if I could just ask a question for clarification. If you go back to slide 4, you have two different aspects that say this task is not a standalone reason for personal care. Is it? Are any of them standalone reasons?
Yes, everyone but the two with the asterisks are. Yeah, thank you for clarifying that.
But I thought you said that they need 3.
They need 3 to qualify for the benefit.
So none of them would be standalone. I mean, if they only had the one, correct?
Yes, in that sense, you're correct. But what we were trying to call out here was that, if, for example, protective oversight cannot alone be the only reason that a personal care worker is coming out to provide the service to the child. Am I missing something?
Now I'm confused.
It's confusing.
If you have to have 3, I guess maybe, let me say it a different way. See if I understand it correctly. You have to have 3 to qualify, but there could be a personal care visit for one only. So if all I needed a personal care visit for was a dressing change, that would be,
okay.
that is a reason for a visit, but I'd have to have 3 reasons to be eligible for the services.
Right, and okay, I think I misspoke in saying that the others, I think I said the others could be a single reason alone.
Mm-hmm.
Yeah, and that's not correct. You do need 3, as you're both noting.
Okay.
So, yeah, that's a correction that's well made.
You're good? Great, thank you.
Are you good, Chairman?
Yeah.
Okay, so moving back to slide 13, the related developments. So like our home health benefit, this personal care benefit does require a child to be assessed for their needs, and a tool is required to do that assessment. So the tool that's been developed to meet this need is called the Personal Care Assessment Tool, PCAT, or PCAT. And I'd like to just share a little bit of information with you about this tool because we've kind of all been down the tool path before. And I wanted to be very clear and specific about how this tool was developed. It was led by our Chief Nursing Officer, Jeanette Jansen, who is here with us today. The work was done by a diverse stakeholder work group, and this stakeholder work group included parents, included providers, medical professionals, advocates. Really, it was an open group. Anyone that wanted to have a say in how this tool was developed and what was included in the assessment was a part of that work group. It was open. The group met over a number of months, and as well as the group meetings, the tool and the benefit were discussed in related meetings, such as the PDPPC meeting, the Children's Disability meeting, the Children's Advisory meeting. So there were many, many venues in which the benefit and the tool were discussed, very lively and very rigorously throughout the months that this tool was being developed. And what I want to really point to here that I think is important to the board is that the work group who put this tool together voted unanimously to approve its use. So I think we have alleviated concerns that we have a tool that is felt to have been developed without stakeholder input and approval. This work group also has provided input on training for how to administer the tool and how the benefit itself will be administered and managed. So that's an area that the department had been criticized for on the PAT. The department's training came under scrutiny and concerns were raised. So with this training for this tool and this benefit, we have utilized this stakeholder work group again to try to answer any concerns that existed about the clarity and the usefulness of the training as it's presented.
Quick question on that, because I think the biggest concern when the PAT tool came out is that it became an end-all point system. That this, you'd come up with this point and then that was the answer. This is a tool that's used with common sense and looking at it individually that could be altered after the fact. I mean, the plan.
So the tool is only, and this is true for the PAT too, the tool is only part of what's used to determine what the child's needs truly are. Well, there will be a letter from the ordering physician. There are plans of care, or for example, a 485, which is used within the waiver population. Any other documentation that the parent, family, the provider, the doctor feels is relevant, and all that's considered together.
Okay, thank you. Ms. LaCombe?
Lessons learned on tools, right? And a lot of tears with that. Have you tried looking at this tool and maybe testing it, getting a sample group to see, because we have a diverse need with children, and maybe looking at a sample group and really testing this tool. Are we missing something here? And then maybe you can adjust it before we actually implement it.
Yeah, thank you for that question. Absolutely, we are in the midst of beginning a test, and because personal care has not been a benefit that's been offered on the state plan side before, we don't have a test population on the state plan side, but we do have a waiver population that's been receiving personal care services for long periods of time. And so we are doing a test of the tool on the 60 children within the waiver population that we have available to use as case examples, so that we can see how it actually affects each child as we score them on it.
Great, thank you.
Just to finish up this presentation, the last slide, number 14, speaks to the final development that I wanted to share with you, and that concerns the home care allowance. Home care allowance is a program of the Department of Human Services, and it is a cash-based program that provides funds to the family to pay for personal care services. So it's a more consumer-directed model of delivery. Our concern with this program was that there was potential duplication of services because both do handle personal care services. So we worked with our partner agency at Human Services to come up with a compromise on this. What we did not want to see was that the new personal care state plan benefit prevented children who had been receiving the home care allowance from receiving that moving forward. So the way the rule reads and the collaboration that we created was that families may keep the home care allowance if they wish. The new personal care benefit does not need to supplant it. They cannot receive both because of duplication, but they may receive whichever one they feel is more appropriate for their family. So that wraps up the suggestions adopted, not adopted, and the developments. that I
Thank
wanted
you
to
for that
share with
update,
you.
by the way. That's a nice way of doing that.
Thank you. Thank you. So at this point, if we don't have any questions right now, I'd like to go ahead and look at the rule itself, which I know everyone here is dreading.
Dreading just because it's very confusing to look at.
Judy kindly provided to the board not only the track changes copy that's normally provided, but a clean copy so that you could really see what the rule looks like. And then also we put together, and this was provided to you, a crosswalk that shows the parts of the rule that were changed at each specific incident. I personally...
Do we have a clean copy? I'm not, is it
There should be-
listed as a handout?
I think it probably is.
If we have a clean copy, I think it's easier to
Handout
work from.
too.
Is it handout too?
But I would ask the board for its pleasure in which copy you prefer to work from.
What would the board like to do?
Clean.
Okay, we'll look at the clean copy, which is handout 2 on our computers. Okay.
Do we need a minute to pull it up, or does everyone have time to? I know it can be hard to open those things up on the
I
iPad.
think we're ready.
So what I want to do is go through 4 key areas of change that occurred to the rule since the last time you saw it. 3 of these are substantive, and of those 2 we already covered on the slide deck. And then 1, the final change, is formatting differences that have occurred to the rule since the last time you saw it. The first substantive change was the addition of the 2 tasks to make a total of 18, which were the addition of meal preparation and the addition of provision of medication reminders. So we did go over that on the slide.
Which page are we on?
Let's see. Those tasks, we get into the list of tasks starting on page...
Mr. President, meal
Yes.
preparation is page 6.
6 of 20?
Meal preparation is on page 6 of the clean copy,
Okay.
and medication reminders.
It's on page 15.
Yeah.
15. Thank you. So those 2 additions are substantive. Our second substantive change was we clarified that clients can choose to receive either the home care allowance or the personal care state plan benefit. Again, we covered that on the slide set, and it is under reimbursement. It is the final section of this rule. It's 8.535.7.c on the very back page of the clean copy. The third substantive change we made was that the definition of CNA, which you'll find on the very first page under definitions, was reworded so that it now aligns and has the same wording as the CNA definition in the department's home health rule. So an elimination of confusion there. And the remaining changes that were made, and all the yellow that you saw in your track changes copy, were changes that were made to comply with refinements to the department's rule template. So we have changed our rule template to be more streamlined, to be more clear, to be less confusing, which I think is a very good thing. And primarily what we did, what this accomplished was it removed excess wording. An example of that was the list of qualifications for the personal care worker that I mentioned earlier, that we now simply cite the CDPHE rule rather than spending a page and a half listing what's already provided there. We also rephrased some of the rules. Again, we had feedback that some of the wording was confusing, and so we refined for improved clarity in the way that the information is presented. And then sections were realigned for improved flow of the document. This document was fairly newly minted when it came in July, and so we found that some of the sections really could be combined in ways that created a better flow, that were more user-friendly, and were easier to read. And a couple of examples of that where we had documentation as a piece of a number of different sections in this rule. We had client documentation requirements listed in the client section. We had provider documentation requirements listed under provider requirements, and those were all moved together under one single documentation area in the rule. So those are the 4 key areas where the rule changed. I do want to note one mea culpa here, I guess you could say. We identified as we were reviewing the rule this week that there was an error in numbering at 8.535. 0.5, a little section was added in, and then the area below it did not get renumbered. So we wanted you to know that we are aware of that, and that we will be requesting a technical correction when we file the rule.
Where again is that?
It's at 8.535.5.
Spot on page 16.
Thank you. So the non-covered services will change?
That's correct.
And everything below that? Okay.
But again, it's a formatting change rather than a substance.
Right.
So that concludes everything that I brought to present to you this morning on the rule, and at this point, I would open it up for your questions.
Questions from the board? Ms. Roberts?
Thank you, Mr. President. I have just the insertion of a word, perhaps, on page 1, line 29 through 31. It appears that that is home care agency means a Class A or Class B designated entity that provides home health or personal care services. I'm wondering, for clarity, it should say provides either home health or personal care services respectively, or just add the word respectively? Because when I saw that, I thought, well, that personal care, it's delineated elsewhere, but it goes ahead and in the next definition says home health agency. But it may be confusing if people are trying to differentiate what a home health agency is, just a simple.
I think we would be amenable to adding the word either or either in front of home health to just clarify that point specifically.
Okay. Page 1. Other questions from the board? Okay, we've got a couple people signed up for public testimony.
Mr. President, that'll be sort of done whenever you get ready.
Okay. Get your wording ready for the record. Great. I have 3 people signed up. First, Bethany Prey. You'd like to come forward, introduce yourself again, who you represent, and your position on this rule.
Yes, thank you, Mr. President and the board. I'm Bethany Prey, and I'm at the Colorado Center on Law and Policy. Well, I think there's a lot that's very good about the rule, and I really do appreciate a lot of the changes that were made, that were discussed today. I want to emphasize before I talk about my other comments that the early and periodic screening and diagnostic and treatment program for children under Medicaid doesn't allow this establishment of arbitrary limits, and it requires an individualized program. And I think that there's a lot of language in the rule that supports that, but I think there are some areas that we would object to. One issue is about the limitation to 3 services or more. We do appreciate that being back down from 4, but believe there should still be some language that would allow a doctor to override that. For example, a child who may have severe limitations, lots of needs, and is getting CNA activities may also need some supplementary personal care and not need 3 additional personal care activities. And in that case, for example, it seems to make sense to me that fewer than 3 might still be able to qualify that child for a personal care benefit. That's on my copy, which is not the clean copy. That's page 6, lines 1 through 2. Then there's a definition of medical necessity that's referenced on page 9 of the not clean copy that I believe is not the correct medical necessity definition. That is 8.076 is the sort of state plan medical necessity definition, and the EPSDT specific definition, which I believe should be referenced here, is 8.280.1. So I think that, as this is a pediatric benefit, that's the relevant medical necessity standard.
Can you help us where this is on the clean copy?
I'm not sure. Where
It's
is that?
8.535.4.A.
Mr. President,
Okay.
that's on pages 3 to 20 on the clean.
Thank you.
Line 7,
Thank you.
right?
I don't have the clean copy, so.
I think that's what you're referring to.
Could you repeat them?
I believe the one that's cited is 8.076, which is, Colorado has 2 separate definitions of medical necessity, one that's specific to EPSDT and one that's a more general definition. The EPSDT definition is at 8.280.1. I think that was probably inadvertent, and I wish I'd caught it earlier, but I do believe that's the correct citation. Let's see. And then there was discussion earlier about school as a prohibited location. And I entirely understand that we don't want duplicative services, that's not permitted. But if the school setting is barred as the place that personal care can be provided, then we're missing the before and after school periods, which are not covered by children's IEPs, which often involve programs that are run by independent groups, not by the school itself. And I want to point out that the Medicaid manual from 2014 regarding EPSDT has language specifically about this. While it's optional for states to provide personal care services for adults in locations other than the home, this is not the case for a child. Under EPSDT, personal care services are to be provided, for example, in a school or group home if necessary to correct or ameliorate a condition. So it is contemplated in the Medicaid manual, and I'm sure that they're aware that IEPs and might cover some of these services at times, so I believe that's still relevant. And my last point was, and I appreciate that there was a discussion that where additional information is necessary, either because the frequency of tasks might be more than is noted in the tool or some other limitation, that additional documentation can be provided. But I want to point out that with this benefit that it is going to be reviewed, medical necessity will be reviewed according to the rule by a designated review entity. That's outside the department. So since that other entity has control over this, and since parts of it are delegated only to the home health care agency, I think it's important that there be language somewhere that makes it clear that parents can get notice that they can provide extra information, and get notice if they have a denial that they have an opportunity to do that, so that it's not exclusively in the hands of the agency, which may or may not be entirely on the ball. But for a parent whose child may or may not be able to access these services, I think it's important that they know and have the opportunity to work with their physician to make sure that everything is provided. Thank you. Those are my comments.
Okay. Questions for Ms. Prey? Could we kind of maybe step back then and hear the department on those 4 points? First of all, again, on the number of services of 3 or more.
Certainly. So for these 4 points, regarding the benefit definition of requiring 3 tasks, on EPSDT, the nature of EPSDT is that anything that a child needs that the doctor orders is provided. So there is an exception provision to EPSDT by nature of its federal regulation that if the services are needed
and are medically necessary.
Please identify yourself.
Dr. Zerzan, Chief Medical Officer.
Thank you.
That they can be provided, but we can't simply bring you a benefit that says we will provide anything and everything that anyone wants. We have to come up with limits for the purpose of the rule. So that's where we have come up with our 3, and I think I explained the reasoning behind that. And Judy, if you want to add any more to that, it stands as part of this whole rule.
Sure. So clinically, both Jeanette, our Chief Nursing Officer, and I have looked at a number of cases and have found it really hard that any child that has needs would not qualify under this. In addition, this is similar to the PAT tool. Other information is included, so there may be extenuating circumstances that would allow someone that only checks off perhaps one area of personal care to get that. So as is listed in the rule, it's an individualized review of things, and so I think that the 3 tasks will cover most children and most children's needs. If there is an exception and there's enough clinical documentation to show that it's medically necessary for services under that 3, then that would be an EPSDT exception, and we would do that.
So shall we move on to the second
Please,
point?
yeah, the definition of medical necessity.
As put forth in the rule, yes. So the definition that is cited there is the department's definition. This is the PUC's definition as set by our program integrity section of the PUC. So they are the ones that come up with one consistent department-wide definition for medical necessity, and that was the one that we were instructed by leadership to use. And it makes sense to me to use because I do think it needs to be consistent department-wide. I understand Bethany's reference to the EPSDT definition, but for consistency of our rules, this is the definition that makes the most sense for this rule.
And if I could add, we actually have 7 definitions of medical necessity in rule, which is extremely confusing, I think, both for us providers, clients, advocates. So we are undertaking a benefits collaborative that's going to kick off next month to start to address this issue and see if we can agree on one definition of medical necessity that will sort of encompass everything to allow for a bit of simplification, because it is definitely confusing that there's so many definitions.
Great, thank you. Okay. And then the third on school-based services.
Right, the before and after school activities, and I actually have not done the research on this. Meredith Henry, who was the manager for this and brought me the rule the first time, might have had that information, but I don't have it with me, so I will go back and check into that and get back to the board and also to Bethany on that provision. I think
Dr.
what I was
Milankovich?
looking into.
I think it definitely bears looking into, because my belief is that kids who have an IEP, that's only while they're in school. The service is only provided while they're in school. There are a fair number of kids who have before and after school care. I have another question, however, about this. Whether a child has an IEP is a decision of the school. And it's theoretically possible you could have a child who was felt to need personal care services that didn't have an IEP because the school did not give them an IEP. They put them on for a 7 plan or something else. Now, I don't know how it's theoretically possible. I don't know whether it would really occur. But what if that did occur? What if it was a case where a child did not have an IEP, and yet by all the reasons, using the assessment tool, the department determined that they needed personal care services? How would they get those services?
In the school?
Correct. But I guess what I would ask is I'd like some analysis or some way to be for the department to look at whether or not that's, even though a theoretical possibility, would never occur. Do you understand the point I'm raising?
So that there are some children that should have IEPs that don't.
That there are some children who should have personal care services in the school.
Schools don't always cover everything that perhaps may be needed, and you have to have at least 2 different areas. So if you have one area, then you wouldn't get an IEP. So I understand what you're saying, and I'm not totally sure. And I think it gets even more hypothetical, because what if the things that were needed for personal care were things like dressing or bathing, and then that wouldn't happen in a school setting? Really? Yeah.
I mean, I just,
and so,
this is a question of my mind.
Yeah, we'll have to look at, I know that Meredith looked into this a lot, and I don't remember the details, so.
I would just like to have a little bit further analysis of it, because districts are very different in how they determine whether a child is eligible for an IEP. A lot of it depends upon the resources they have in the district.
Ms. Roberts?
Thank you, Mr. President. And to dovetail that, what happens when a child is identified as being applicable and needing an IEP and the parent or guardian chooses not to? Is there any way to be able to circumvent that so the child actually receives the benefits that that individual needs?
Within the school setting?
Yes.
So, thinking about it, there may be one way to solve this. What if we made a change to the rule that said that it's not provided in school during school hours? Because what we're trying to avoid is that duplication of services and having the school be responsible for what the school should be responsible for. Certainly, I know there's a number of advocates and other resources if parents don't feel like their kids are getting what they need in schools to sort of help push for that. But that's the piece that I think we're trying to avoid without being in the schools, of not paying for something that the school is paying for also.
Mr. Massey?
Thank you, Mr. President. And it's a very good question, Dr. Malikovitz, because schools typically look at IEPs as ability to learn at grade level rather than a personal care service driven model. So it does make sense to look at the differentiation.
I did just receive information, though, that the children with IEPs do have services covered during the before and after school period. So that is actually provided.
They may have services. It all depends what's in their IEP. Yeah.
So I think that we're going to revisit this, and we can get back to you with specific information on the questions that you had, Ms. Roberts and Dr. Malikovitz. And we'll look at the changing the rule wording to try to cover so that all of these instances are.
Thank
there
you.
are no gaps.
Thank you. And the fourth one is really that process, and I think it's what Ms. Lacombe was talking about too, is just having this rule be very clear that it's not just this tool, that that we can get additional information from medical providers, as well as then an appeal process, or kind of the backdoor side of that, if what are the next steps. And I'm not sure, without reading through the clean rule, if it really states that well.
So the benefits collaborative part of this policy does state that a bit better, I think. And this is one of the struggles that we're having with putting the benefits collaborative into rule language, because our usual appeals process would apply to this benefit. So I think it would be redundant to put an appeals process in the rule when the appeals process applies to all of our benefits. But that being said, we are developing a training for agencies to use, and I think this may be a place for that. And I think we're also developing a frequently asked questions document for parents to use or caregivers, and so that's probably a place for that if you feel like there's additional information that needs to be required. So I don't think that part needs to be in the rule.
Where would they find it, though? And not where you'd put it all down in here, but could it be referenced?
Yeah, so I think all of those things are going to be posted on our website, and the trainings are. I don't know if you want to add that. And we have a benefits collaborative section of our website, and our website, as I think many of you know, is very new and improved, so it's much easier to search than it used to be. So if you put in personal care in the search bar, I think that these documents would show up. Yeah.
We actually have personal care web pages now, one for providers and one for families. So you can't just put it in a search, you don't have to know where it is, you can go to it, and these documents will be there. We do have an FAQ sheet that you mentioned for families to clarify this. And I think one of the things that's been very helpful about the process and this benefit is that parents, advocates, providers have all been involved in the tool and discussion of the benefits. So we do have a more educated group for this benefit than we did with the PAT, as far as understanding how much documentation they can submit, how to use the assessment tool to explain extenuating circumstances.
Okay, thank you. Other questions from the board? We have two other people signed up for public testimony. Gwyn Blodgett, not sure if I pronounced that correctly.
You did.
Oh.
Kind of being in this part of the room.
I'd like to introduce yourself, who you're representing, and your support of this rule.
Good morning, Mr. President and the board members. It's kind of odd being, like I said, on this side. I am formerly from HCPF. However, right now I'm just really working in the community and doing some contracting and whatnot. And I did want to say I have been involved with personal care even after I've left the department. And what I've heard is very positive. This is a benefit that is needed, that the rule is looking actually quite well for this, and that they're taking steps to really avoid any of the problems with the PAT tool. I did want to mention a couple of areas that I just want to make sure that we're really, they really pay attention to. The biggest one that I've seen in the rule is that there seems to be a lot of blending between Class A and Class B, and I think that has to do with a lot of the confusion around them. In Colorado, CDPHE offers licensure under Class A, which is your medical, and your Class B, which is your non-medical or your personal care services. Agencies who are Class A only may also provide services as a Class B provider, but they still have to meet all of the medical requirements under what Medicare certification and Medicaid means. And so there are a Class A agency may also get a second license and be as a Class A and a Class B, and they get to follow the rules associated with the Class B and the rules associated with the Class A exclusively. So if you have a Class A agency that is providing services, they need to continue to get that 485 or other like document, which is not included in this, and they need to get it from a doctor. They cannot get it from an advanced practice nurse. Class B agencies are not as strictly regulated in that piece, and they don't really require any real physician oversight to provide the services. And so I just want to make sure that that's clear in here when we have a Class A agency, that we are enforcing the rules up to what their regulations are, and that Class B agencies do. So the one thing that I wanted to bring up based on this is that under the behavioral interventions, which is the place that it's mentioned, it says that it's the behavior, but then it goes outlined on the CMS 485 plan of care defined below, which it is, and that is the area that includes any of the regulations that a skilled or medical agency would need to have completed. The class, or the CMS 485 is a specific form, and not all Class A agencies use that form. I know the home health rule did state something along the lines of CMS 485 or document with exactly the same information on it. And so we want to be careful of inadvertently tying them to that one tool. And then the other thing, you guys mentioned in the ordering provider, which is what brought up the other part of my statement, means a licensed primary care physician, advanced practice nurse, or specialist who is responsible for writing orders and overseeing the client's care plan. So once again, we have in this section, skilled A agencies cannot use advanced practice nurses. It's prohibited by CMS. We would love to see that lifted, and we keep being told that it is being reviewed, but it's an archaic fraud protection measure that CMS put in place many, many years ago and hasn't, as of yet, lifted that. The other thing that I would like to point out, and it's kind of through the entire rule, and I'm sorry that I didn't point this out sooner, I probably should have, but under each of the, or most of the personal care tasks, the last section, if you go to any of them and look at the factors that make the task skilled, that last statement before going to the usual frequency says that in order for it to be a skilled task, there is a documented decline in condition or ongoing need documented in the client care. I don't think that's the appropriate place for it unless that's truly that we want to automatically make personal care skilled because the client has experienced a problem in their care or that they're an ongoing decline. That was originally put in the Home Health Benefit Collaborative in the, I believe it was the special circumstance or something like that, saying that in order to go out continuously and not have a defined discharge plan, that the client had to have documented ongoing need for these services. And so I don't expect that we meant to say that they have to, in order to have skill, that they only need to have some sort of a change in their level of care or that they have an ongoing need. So.
Okay. Response from the department on those?
I am not sure I'm clear on the change that you are suggesting.
Okay, yeah, that makes sense. Sorry. I think that it's very important language to have in there, but it should not be under that section for what makes it, because, let's see, the section has factors that make task skilled. We have the client requires assistance, and what defines that. We have the client is unable to assist or direct care. We talked about them having, in some of them, an exacerbation, but always that last one says there's a documented decline in condition or ongoing need documented in the client's chart. So as an example, if you have a client who's receiving a bath, and they need to continue to have this on an ongoing basis, there's documentation that it's a personal care and that it's an ongoing thing, is the department intending to make that automatically a skilled? I guess is my question.
Good point.
I just think it's in the wrong section. I definitely don't take it out. I just think it's in the wrong numbering.
Where are you recommending that it would fall?
I think that it would be a wonderful either C before the usual frequencies, or it can go into the special considerations, which is that next one. So yeah, I definitely don't think we should get rid of it because the client, we do want demonstrated ongoing need for that. It shouldn't be under that particular section.
But you're suggesting pulling it out from under B?
Yes, I'm suggesting pulling it out of B and either adding it to its own section or to put it under the special consideration section.
Dr. Young?
Yeah, I have a question on that then. On the factors that make a task skilled, are those ands or ors? I don't see and or in any of that list, and so that, because if that's an, anyway.
They would be ors.
Okay.
So any of these factors would make the task skilled.
So that probably needs to be clarified too, I would think.
That's a good point, I missed that too.
We can add these, so many eyes have been over this document, and it's been changed so many times. But if that's something that will make it clear, then we can certainly add that to each of the tasks in the factors that, in specifying that any of the factors below would make the tasks.
Yeah, just an or after the second to last one would probably clarify.
Okay. Certainly
So
we can
that
make that
we don't
change.
have to meet all the requirements, and I think that ties in with this question about, does it fit there or not fit there?
Otherwise, that's the end of my comments. As I said, I think this is very well done. Having participated as a stakeholder side, it's been very easy to get information and to be invited to the meeting, so kudos.
Thank you very much. Any other questions? All right, thank you very much. The last person we have signed up for public testimony is Sarah Engels. If you'd like to come forward and identify who you represent and your position on this rule.
Good morning. So I want to give a little background before I go in. I'm with People Care Health Services. I'm the owner and administrator. We actually serve 52 out of 64 counties right now in Colorado, primarily in rural counties, so Baca County, Routt, Moffett. And this program, this benefit, is very much needed, so very much in support. I kind of want to go back a little bit to also the development of this. So the July meeting kind of predated me. However, I've been involved in the PCAT development, and I'm also involved in the Children's Advisory, Children's Disability, the PDPPC group, where these tools get discussed. And numerous times have there been opportunity for families, for stakeholders, for providers, for involvement. And so I would like to actually commend HCPF in how they have done that. So again, I don't know what happened prior, but I can tell you afterwards, we have been invited to test the tool. We have been invited to be involved in giving suggestions for how to train on the tool as a provider, and I think they've done a very good job of getting that out. The debates have been very productive. I think people have brought up a lot of different things from the Children's Advisory Group, where we've had medical professionals on, we've had providers, and the dialogue has been very positive. So I think that by the fact that it's coming to you with a lot of support, it shows a lot of work on behalf of everybody. So I wanted to start by saying that. The other thing is the use of the form has been discussed. So when we talk about the tool, to your comment about, do we understand that it's a tool, that it's not an end-all be-all? Very much so. We've also talked about the understanding of we have had wonderful support from Janet coming in and telling us why certain rules are certain rules. So even though as a Class B provider, and I understand I'm on the Home Care Advisory Committee as well, I certainly understand regulation. Not all of the people that are involved in those meetings do understand regulations and rules. So to have someone be at all of those meetings to be able to advise why is something skilled and why is something non-medical or unskilled in nature, is it DORA, is it regarding the Department of Health, and explaining why behind it, I think gave a lot of insight so that the committee could actually move forward very successfully in understanding how that tool is being utilized. With the comments that were made about additional documents, I also think as an agency provider, which are the ones that are providing this service, we do understand that that happens a lot. We work with our fiscal partners, with HCPF, with SEPs, with all kinds of case managers to say, this person is not a cookie cutter, right? I mean, we can't do that, especially in different counties when we're serving children and we're serving different populations. Even though that this is definitely rural, we also realize that there are real people involved and that we can't just stamp them out. So when we have certain situations that arise, we do work together collaboratively to make sure that the client, the child in this case, gets the services that they need one way or another, whether that's working with the school or whether that's coming back to the state and asking for an exception. So I just want to point that out as well, that I realize that here we're making a general ruling one way or another, but in the real life application, it's not quite so simple sometimes, and we do have to be advocates for our clients and for their families, and that's part of our job as a provider. That is in our regulation. I also want to talk about the fact that we have done a lot within the wording of the form of the PCAT tool. So when you read through that, while words may seem like they were just put in there, I think from anyone who's been on the boards, if one's still here, there was a lot of conversation about specific words and why those words were chosen. If someone were to read the tool directly in front of a child and in front of a family member, would that be offensive or would that be understood? So I, again, want to say I know that not everyone is involved in these, but these, up to 3-hour meetings where we're discussing one word for an hour, it's not taken lightly. You have a lot of people that have a lot of insight and a lot of work with these families directly. And I think the tool is very valuable. Again, it's not a stand-all be-all on its own. Everybody understands that. But I do think that they put a lot of time and effort into it and even separated it out from a Class A version or the skilled version of that tool to a Class B version, because there are certain rules that as a Class B agency we do have to follow that are different than Class A, so we can't utilize the same tools. So even that side of getting the stakeholder feedback and working with the Department of Health, because we are surveyed, we want to make sure that we're in alignment, and I feel very comfortable with that tool. I would also, I guess, just like to say that I appreciate the opportunity that you allow public comment for this. I think a lot of times we're the ones that nobody sees or hears, but we're the ones in the homes and on the first line defense going to bat at the schools and some of the other places. I believe the Department of Health, HCPF primarily, I serve on numerous committees, including the IHSS that you just reviewed, the openness and the transparency in which all of the departments have been working together have actually been very inspiring to me. I have a lot of families that want to get involved now because they feel like they're actually going to be heard for a change. So again, on a side note, I think that you need to commend not only yourselves, but the Department of Health and HCPF for their work and effort in making sure that we all are heard and understood, and they've made changes that we've made suggestions on. So while I think there might be a few tweaks in words, I do think that it should pass with those tweaks, and we should implement as soon as possible, because again, in these rural counties, there are no home health agencies. There are no hospice. We have limited doctors. By the time they can see their doctor, it's several weeks after. They need the services, and so the faster that we can get this implemented, although maybe it won't be 100% perfect, we can iron out those tweaks because of our collaboration.
Thank you very much for your comments. I appreciate that very much. And I think all of our direction is to create rules that allow the advocates to continue to be advocates, to really help people with their individual needs. So I appreciate everything that you're doing there.
Absolutely.
Thanks. Questions or comments? All right. Thank you very much.
Thank you.
Nobody else has signed up for public testimony. Would anyone else like to? It's not. Other questions or comments from the board? We've talked about some changes. Does the board feel comfortable with final adoption, or need to see some changes before bringing it back?
I'm comfortable going forward
Okay.
and with permanent adoption.
Yeah, I'm comfortable going forward. I would like a little more clarification around the school days. But that can be done afterwards.
Right.
Yeah.
Okay.
Agree.
Well, we do have a motion and a second for final permanent adoption of document 7. So all those in favor signify by saying aye.
Aye.
Ms. Riley?
Aye.
Mr. Fox?
Aye.
All right, thank you. We have permanent adoption of document 7, and we look forward to hearing how this is working out in the future and some of these clarifications as we move forward.
Yes, we'll definitely get back to the board on all of the points that were raised.
Thank you very much for simplifying a very confusing rule for us all.
No cartwheels on ice.
All right, if I could have a closing motion?
I move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second.
Got a motion and second. All those in favor? Aye?
Aye.
Aye.
Ms. Riley?
Aye.
Mr. Fox?
Aye.
Very good, thank you. And we don't have anybody signed up for open forum. Would anyone like to sign up for open testimony? Seeing none, we'll move on from that portion of the agenda. And we are set for department updates. Are people okay, or should we take a quick 5-minute break? Break. Okay, we'll take a 5-minute break and start up again at 11:15. By Parrish Steinbrecher? Brecker? I was going to guess Brecker, and I went away from it. All right. Welcome. If you could introduce yourself.
Yes, good morning, Mr. President and board members. My name is Parrish Steinbrecher. I'm the division director in the provider payment division. I oversee the MMIS and basically most of the IT within the department. So I'm here today to give you an update on the status of a very huge project the department is working on. It's called the Medicaid Management Information System. My presentation, I wouldn't normally probably give you one based on some pictures of some gentlemen on the moon. So I hope I am invited back here to give you updates that more specifically apply to you. But I was given some feedback that sometimes systems updates can be a little dry. So, basically how this started is a couple of weeks ago, I had an opportunity to see this TV program and some of the conspiracy theorists on the Apollo landing. And basically everything that I see on TV or hear, I sort of relate to this project that we're working on, okay? Because I spend so much time on it. We have a project, it's called Commit. Now our Commit project, which is what the department's working on, is what the MMIS is. I'll go into it in a little bit further detail, but so basically everything I see, I relate to the Commit project. And so when I started hearing this conspiracy theory, I started thinking how similar actually this is to our project. Because for this department, this project is like an Apollo mission, okay? It's very similar. We're implementing a brand new technology here, and it's going to allow us to do a lot more things. So if I am, I started thinking, if I'm on this lunar lander, and I'm Neil Armstrong, and I'm about to step out and step on the moon, what am I thinking? Like, what's the ground going to be like? What's the environment going to be like? Like, how did I even get here? It was a little bit of a leap of faith, We are taking less of a leap of faith because we are actually going with the CMS certified system in 13 other states. We've done our research. We know what it can do for us relative to our current system. So it's less of a leap of faith, but it is still something where we get asked questions all the time. Can you specifically tell us this? Can you specifically tell us how this system is going to improve my life here, here, and here? And we're working our way through that. And I'm going to go into that a little bit for you here as well so that you can understand the impact of this project on the department. So how did we get up here? Like, we didn't, in the Apollo mission, they didn't have smartphones, they didn't have tablets, they didn't have laptops, We had a leader that said that we would do this project. Well, this project, as a result of this department, is actually, every leader in this department has basically said, we have to get a new MMIS so we can execute our policy and strategy going forward. So it's not just one person, it is the entire department, and as such, it affects the entire department. So this is a good picture right here of the actual Apollo guidance computer team. And how we got here is because we have a bunch of smart people working together. You guys have seen today that we have a bunch of smart people in our department that are working together to form policies. Well, that's how we got up to the moon as well. We had scientists, we had engineers, we had a ground crew and the astronauts. So all of us have to work together to implement this project. This isn't my division with a bunch of people coding technology, implementing a system that people aren't for sure going to know how to use. Everyone is working together to implement a brand new claims adjudication system that I'll talk to you about here a little bit further. So how does this benefit us? All right. Generally speaking, at 100,000 foot level, this is going to support our HCPUF's business model going forward, which is going to allow us to adapt to the next decade's healthcare transformation. That's payment reform. It's going to advance payment reform. It's going to advance the ACC. What this system is it's interoperable. So this is adaptable to changing technologies. You may be aware of something called apps and smartphones on those apps and how that's pretty new. I mean, this is where we're going, and we have to have the ability to implement projects quickly and based on our department's priorities, changing needs. One of the interesting things that's been brought up is that this is going to allow us to transform administrative and clinical data into true population management practices that the department can actually impact quickly. So this system is huge. And I'm going to apologize in advance for some of the eye charts that you're about to see. In the future, your optometrist will see you right after this. But the benefits, but it's not just a state benefit. This is also a department benefit. So someone comes to me and says, Parrish, what really, for my unit, how does this help me? So the first two things I talk about is I say, well, this is going to eliminate manual workarounds. This is going to free up staff time. This is going to free up your time. This is going to free up dollars. This is also forcing us to work together because of how quickly we can now implement changes versus if we get a project and we have to go to our current vendor, it could take 18 months to implement something that we could implement in 30 minutes in the new system. So we're going to have to work together more closely, and we're going to get to know each other's jobs a lot more, and we'll be less siloed. The other thing is that, like I was saying, changes to the system can happen as we prioritize them. We're not limited by what the current system can do. So I had mentioned 18 months. That's not unrealistic. We have a current system that is written in 1978's COBOL. So anything that gets changed, you have to go in there and make sure that this code change doesn't affect this code, change doesn't affect this code change. It takes a long time. So that's why we're doing this. Now, how are we doing it? This is just a small chart just to give you an idea of how this works. Xerox, our current fiscal agent, operates our MMIS. That's our BIDM, most of our BIDM, and our PBM, Pharmacy Benefits Management System. So what we've done is we've hired contract staff. These are not full-time state employees, but they are very good contractors that we train, we interact with on a daily basis. They sit over in my division, and they work, well, not just in my division, someone's hung up, not just in my division, but also in divisions around the department. So we interact daily with them. They keep our operations and our systems running for our claims adjudication system. Now, our current staff, we asked, what do you want to work on in the future? Do you want to work on the old system, or do you want to work on this new system? And most people want to work on the new system. So we have them working, all of our current staff, which has most of the subject matter expertise, are helping us implement. Okay? These three bottom boxes, you'll see Truven, which was recently announced as our business intelligence data management system vendor. HP, Hewlett-Packard, is our interchange, and that's the claims adjudication system. Our pharmacy benefits management system vendor, we're currently reviewing the responses that came back from our most recent RFP, so I'll show you the timeline here in a minute. So we're working with them to implement a brand new system. Now, what does that mean? Well, it means that we have to have all of our experts sit with their experts and make sure our system works correctly. So here's the eye chart. This is the beginning of it. All right? This is just to give you an idea. What we have on the far left are what are called functional areas. I wouldn't try to interpret them and what it means exactly to you because it probably is not what you think it is. But it's all of the areas that we need to make sure we validate that A, the contract requirements are met that we as a department wrote and we require to operate effectively. But we go through all of these and then you'll see dates, start and end, okay? Those are sessions. Those are individual sessions that each of our staff members here go through. So in addition to what our staff currently does, we've added this responsibility. We have a plan, and we're not just adding work, but that's how large it is. Now here's a time frame of where we are. Okay, you'll see we're not even halfway done, but we've already come a long way. Our BIDM contract is scheduled to start on May 1st. Our PBMS contract is supposed to be awarded on May 21st. You're going to see 2 contract awards there, so excuse that second one out there in November. But you can see that we're starting up to implement these right now. So we have staff going to sessions for the interchange right now, and we're about to have them start going for the business intelligence data management system as well. And that's going to be the analytics. All right, that's where we'll be able to eventually have clinical and administrative data working together. So, do we work in a vacuum in healthcare policy and financing? No, we don't. We have to report out to the governor's office. I specifically printed this out so that you could see a report, and there's a little green box at the top, overall project rating. That's good. Yellow or red is bad. So this is what we report to OIT on a monthly basis. This is what they report to the governor's office. Currently, our project is on schedule and on track. Last page, I just wanted to give you guys an idea. We've completed 75% of the requirements sessions. There's basically two phases. There's requirement sessions that our staff will be going to, and then there's design sessions. The design sessions are where we're going to actually design how we want the system to work in the future. So we are 75% complete. And that is all of us working together. That's not my unit implementing this. This is all of us working together. It's quite a task. We're already 20% into our design and definition phase. So as you can see, there's a lot of sessions, there's a lot of work being done. It's a very important project. It will impact all of you in one way or another. And like I said, normally my presentation would be more dry than this. So hopefully I get invited back to give you guys updates on specific impacts based on your feedback. So thank you very much. Questions for Parrish?
Let us know what you find out about the lunar landing.
Well, I didn't want to go too much into detail on that. I didn't want to make a mistake.
Thanks. Can you explain a little about what the BIDM project, what are the deliverables of that? What do you expect to get out of that?
Well, we expect to get, we actually have an environmental roadmap of what we expect to get out of that in terms of collecting clinical and administrative data so that we can provide, I guess it's hard for me to explain. Chris Underwood's here, who's my office director. He might have something better to say along those lines.
Hi, I'm Chris Underwood. I'm director of our Health Information Office. The COMMIT project's broken into three major components, and Parrish's great presentation on the interchange, our new MMIS with HP, is kind of his primary focus. Our BIDM is more of a focus of our decision support system. So for folks in the room that aren't used to our acronyms, the BIDM is the business intelligence and data analytics side of our department. And so right now we have a decision support system where you take in all the data from your MMIS and claims data and you put it into a big database. And then we have a whole group of analysts that sit over there that query this data and use it for analytical purposes and give us results and reporting purposes. And when we have rate setters who go in this data, we are, believe it or not, even with our database of the data we have with our analytics and our skill set, we have some of the most advanced analytics and capabilities of any Medicaid agency right now, just for the pure fact that our folks can actually query almost all the claims data. Other states, if they want data, they call their MMIS and they write a static report. It takes 2 weeks later and they get a piece of paper, here's your data. That still exists today in a lot of state Medicaid agencies. So we are actually moving forward with our data analytics that is, so far as we've seen, no other state Medicaid agency has requested yet. We are not just saying we want administrative data from our claims data. We want actual EHR data from physicians' EHR. We actually want data from every state agency we can come up with. We have approximately 30 databases, 30 to 40 databases across the state. We're actually beginning to incorporate into our data because we don't believe that you can limit healthcare analytics to just claims data and healthcare data. We believe that there's population out there that are impacting clients' health. There's probably a lot of healthcare being driven by the pure fact that kids are maybe in poor performing school districts. And so we'll never be able to tackle that as a healthcare agency if we actually don't go to the school district and help them out in some way. So we have this larger philosophy of population health and population analytics. If we really want to begin to bend this healthcare curve, we have to do more detailed analytics and begin to find these correlations and causations between data out there and our clients' population. So we have built a huge, robust, not a database anymore, it's a service. This data isn't going to sit on state servers. It's a company that will come in and host the data for us, host all the tools, and our analysts will be able to get in that and do new detailed analytics. Now, on top of that, it also replaces our current SDAT. Our current statewide data analytics contractor for our ACC will be merged into this system. So now we'll have one vendor who is doing all of this analytics for our ACC population and our providers in the future. So we have a very optimistic viewpoint of what we can do with data analytics, and we are hopefully with this new VIDM contract breaking new grounds. We've had multiple state agencies calling us already, or multiple other Medicaid agencies calling us already, like, what are you guys doing out there in Colorado? Because your new interchange, your new analytics are the talk of what's going on across the country right now, of how you guys are transforming Medicaid, and so we want more information about your procurements. Now, right now with the warning, I have not signed this contract yet. We just awarded the contract. It's been awarded to Truven, and we are going to go into contract negotiations with them the next 2 weeks, and hopefully have a contract signed by, I think it's May 1st, my goal?
Yes.
To have a deadline, to have a contract signed. Believe it or not, that's how long it takes to negotiate a contract of this size. And then they will be up and running and operational come November 2016, along with the new interchange that Parrish's division is implementing.
Great, thank you.
So based on what you're saying, this is very exciting. Can the board expect then going forward that the department will have the opportunity to run reports, and maybe there's not direct correlations between some of the rulemaking that occurs and all that, but that would be really interesting to look at the outcomes related to policy, and for this board to see what kind of downstream impact some of these things that we are doing here have. So based on what I hear you saying is that we will have the capabilities and the data analytics to do that.
Yeah, that would be a great thing to be able to look at. We should have the data. The question is, how do you build the algorithms and the analysis to be able to do that? Right now, what we do is we will change a code, right? We will change a rate of a code. We will change something in the system, and we never know what happens when you push the balloon on this side, how it pops out over here. So you're constantly chasing your policies of, well, let's change this and let's see what the result is and how it changes provider behavior. But it's almost always a guessing game sometimes to see how providers are changing, because you never quite know, are they changing the right direction when you change a policy or procedure. And so, yeah, that's definitely something we need to get more detail on, and how to be able to do that analytics. So along with, we aren't just hiring someone to host data for us and host tools for us and bringing new fancy gadgets. We're actually hiring a vendor who is bringing close to almost 30 to 40 people that will help the department begin to advance its analytical capability and bring that new knowledge to us.
I've heard a lot of discussions about metadata as well in other areas. How does that apply to this particular system that you're looking at?
Yeah, so when you talk about metadata and data structures, metadata helps you get data on your actual data in the system.
Right.
So it's all about how you structure it and how you formulate it to get your analytics faster and better. So I don't have the exact answer on you exactly what the metadata data levels will be, because we didn't ask for that in the RFP. What we told them was, you're going to bring a service to us. There's over 1,000 requirements in this RFP, and you will find that very few of them are technical in nature. What they are is, we want a service. How are you going to bring that service to us? And we're letting the vendor bring the technology and how to structure the data and how to do all that to us.
Gotcha. Thank you.
Thank you. Other questions? Best of luck. Huge undertaking. Appreciate everything that you're doing on that. Thank you very much.
Thank you.
Next, we have a provider recruitment and participation update, and Gretchen Hammer's going to come forward and do this on, what, day 5?
Yes, yes.
Right?
So it's very nice to meet you all. I'm Gretchen Hammer. I'm the new state Medicaid director, and the department was nice enough to not have me sitting up here today and to allow me to observe, although I have been here before in my previous life. For the last 5 years, I've been the executive director of the Colorado Coalition for the Medically Underserved, and have at times come to visit you all in that role. Today, Marcille Case is actually was supposed to be here to provide this, but she is quite ill, and so I offered to do it simply because that one would give me the opportunity to meet with all of you, but also because Marcille and I have been working together through the National Governors Association Workforce Policy Academy, and so I happen to actually know a little bit about this topic, and also think that it's a topic, even in my first 5 days, that is going to become something that we're all going to have to pay a lot of attention to. Certainly at the SMART Act hearing on Tuesday, this ability to understand how people are accessing the healthcare system, given the coverage changes we've made, is an ongoing area of interest, and I know it's an interest of this body as well as the legislature, and for all of us who've been working so hard to transform the healthcare system. So I know the time is late, and the conversation has been very complicated, so I will let Marcille's presentation be part of the official record, but wanted to just begin by saying that healthcare workforce as a topic, thank you, sir, is really a broad conversation. As you all know, there are many providers who participate in all kinds of health insurance products, Medicaid being one of them. And so when we talk about access to care and issues related to workforce, it really is embedded, the conversation we're having about Medicaid in particular is embedded in a much larger context of healthcare. And it's a very local issue. We've talked, people don't really care in Colorado Springs how many providers there are in Fort Collins. It's really just not that interesting to them because that's not their natural community of care. And so while we're a statewide entity, the recognition that access to care is really a local issue and an issue that is a very personal issue as well. For someone who needs something specific and it may or may not be available in their community, it feels very personal. The data is limited on workforce, and not just here at the department. The Colorado Health Institute was kind enough to invite me to speak at their Hot Issues in Healthcare on issues of workforce, and they are some of the smartest people in the state on issues related to data and availability of understanding of issues. And they also concede that data on workforce is a very limited commodity. It's very hard to know. And so it's nice to follow the MMIS presentation because I think, as you just heard, the new system will give us hopefully an ability to understand a lot more about Medicaid and access to care in Medicaid, but in reality the data is quite limited. And then it's also a very complicated issue. Issues of access, and this is where Marcille's presentation begins to dive in, is, and I move forward by doing what? This side?
I think you just click.
I do, okay. That access to care is really an issue that has many components. The first, of course, is coverage. And so here we think about the notion of being covered by Medicaid. And then there's the notion of potential access. Are there providers in your community that would potentially see you since you have a Medicaid card? We know that in particular, some folks, sometimes that's not true. There may be a provider, but they may not be accepting Medicaid. And then is that provider appropriate? Is that the kind of provider you need? Is it culturally appropriate? Do you feel comfortable going there? And so there's really that then notion of realized access. And the gap between potential access and realized access are really the barriers to care that we all have to work to figure out. And so access is a complicated issue. Oops, wrong, I keep doing the wrong one, I apologize. And so Marcille provides a basic history here of recognizing that access to care within Medicaid is a historic problem, but one that we aim to continue to try and improve on. There has been, as you know, a great expansion in the state of Colorado of the number of people who are covered by Medicaid. There has been a dedicated providers relations unit that was established in anticipation or to address some of the opportunities to improve and to increase the number of providers who participate in the Medicaid program, as well as to begin to address some of the historic challenges. So what Marcille's tasked with and parts of the Health Programs Office are really around, oops, I did go too far. How do I go back if I went too far? Thank you.
You learn all this in week 2.
Okay. Thank you.
You're okay.
I still don't know how to work my email. Again, since access is a complicated issue, there's a lot of different areas of focus. So there's the issues of of improving access to care as the overarching goal so that people can get their needs met. And then also identifying barriers from the provider participating side. So the barriers can be on both sides, for the patients as well as for the providers. The streamlining of administrative processes, a goal of this administration overall, and certainly of the department. And then the notion of what kind of care do you get once you are getting care. And that, again, is a large transformation, right? We're moving toward integrated care for behavioral health and physical health with the SIM grant, but also overall, just can we have a healthcare system that makes a little bit more sense for everyone involved? Marcille provides and she said that this slide is part of the slide that she gives out in the public to help remind providers what the benefits of participating in Medicaid. A very fast payer, there's now 20% of the population at any given time may be part of Medicaid, so there's some market share there that's probably worth considering from a provider perspective, and then the benefits and preventive services that are part of the Medicaid benefit package. So there are 4 major strategies, and again, given the time, I won't go through each of them, but they relate to issues of reimbursement. As you know, as the state budget has improved and the economy has improved, there's been a dedicated effort at the department to improve provider rates, to do that in very strategic and targeted ways, and in ways that make sense and hopefully align with the overarching goals of our healthcare system and of the department. There's been a strategy around administrative improvements, so recognizing that getting a packet that's this thick to become a Medicaid provider is probably not the most welcoming way to begin a relationship, and so working very hard to try and improve the administrative side. Working again on benefit design so that providers are confident that the ability to take care of the patient as they deem medically necessary, not a blank slate, but medically necessary, is an important piece of the benefit design. And then the overarching strategy of delivery system innovation. I know you all are very familiar with the Accountable Care Collaborative program, but also integration and then long-term services and supports. And the ever important attempt to make the better connection between the large gap that exists between community-based wellness prevention and health promotion and delivery system, and trying to the best of our ability to improve that. So healthcare workforce development, one of the challenges again that we've mentioned is that there's lack of data on this. It's also not a quick and easy thing to automatically begin creating different kinds of healthcare providers, and so it's a long pipeline, and I think that there's still an active debate in the healthcare community about what kinds of providers we will need for the future. The new case manager, care coordinator, patient navigator bucket of people that we're calling 10 or 15 different things, is there some sort of new provider that has more behavioral health skills and physical health skills in a single entity, so we're actually integrating within a provider as opposed to even across. So those are all questions that are out there. The initial outcome metrics, an increase in Medicaid provider enrollment, an increase in primary care providers in the Accountable Care Collaborative, those who are within the Accountable Care Collaborative being more closely tied to their primary care medical home, and then an increase in services. Hot topics and next steps. There is, I've been talking generally about providers. We all recognize there's a difference between pediatricians who've had a long history of working with the state Medicaid program, primary care providers, our FQHCs and others, and then the specialty care community. And so, again, not only is access complicated, but the provider community is complicated as well. So working to better understand that, expanding the use of these new kinds of healthcare provider types that we're all trying to understand. Again, continuing to work on reimbursement rates and leveraging all of the great new technological advances that Chris just described. So Marcille leaves here with an opportunity to continue to work with the department on this. I think, again, in my short 5 days of being here, 4.5 technically, I have already thought that this is an opportunity for us to begin to think more broadly about how do we understand when we might know some of the answers to the questions we all have, which is how quickly can people get their care they need, and to cadence that out and really understand that. And so I think Marcille is excited about that. I've talked to Bill Heller about it. I know Dr. Zerzin's been excited about that. So we'll continue that conversation. And then I did not put the slide of the bulldog in, but I think it's quite funny. My husband grew up with a dog that looked just like this. His name was Friar Tuck. And my boys, he lives with us, even though he was a childhood dog of my husband's. So she quotes Winston Churchill here, and you can call this dog Friar Tuck if you'd like as well. And then she also says thank you.
Great. Thank you very much.
So I have a comment. First of all, congratulations.
Thank you.
And welcome.
Thank you.
One of the things that I just want to add, I think that was a great presentation, and it's exciting about what's happening, but not to forget the Institute of Medicine report, which also talks about the scope of practice for other types of healthcare workers beyond physicians. So I think that's another factor in exposing our community to better access and ensuring that obviously the right skill set is there to provide the level of care, health, not illness care. So I just want us as a state to be considering that as part of our activities as well.
Thank you.
Dr. Malkovich.
Thanks for the update and congratulations. We'll enjoy working with you, I'm sure. It seems to me that one of the fundamental questions here is how does the department measure access to care? And I mean, what we frequently see is number of people enrolled, which we've done a great job, the state has done a great job with enrollment. We never see any data that says this is how well we're doing with providing access. And I think it's a community responsibility. I'm not saying it's the state's department only. I mean, it's the department's role only to make sure that people get access to care. But I think as a state, what we really need to do is start figuring out a better way to really measure whether or not people are getting appropriate care. And I think there are some basic measures that we could look at. And what I would like for us to occasionally see at the board is data that the state is using to say we think people are getting appropriate access to care.
Terrific. Well, it happens that there's sometimes synergy in life. And so at the Coalition for the Medically Underserved for the last year, we've been working with the Colorado Health Institute to develop an access to care dashboard. And it has 20 measures on it that are broken down into those three groups of coverage, potential access, and realized access. And the measures that were decided upon by the stakeholder community and CHI allow for that data dashboard to be run by certain demographic populations as well as geographic populations and by coverage. So we could potentially, and I'm not making promises here because I've been here for 4.5 days, but we could potentially work with CHI on that access to care dashboard in the short term and begin to see if we run it just for Medicaid, if that begins to help answer some of those questions. And again, we recognized and tested it with both demographic communities, so the Black Health Collaborative being an example where we engage with them from a demographic perspective, as well as regions. And again, we all know the health statistics regions don't get down to the county level. That's not very satisfying for rural Colorado. But that may be a place to begin in addition to what's already in place at the department for measuring that kind of thing. Do you have anything?
Yeah, so when we do site visits for our managed care organizations and the ACC, it's one of the things we look at, but I would say that measuring access is really imperfect, and I think even the CHI report on this is like, well, there's no good gold standard measure for access. We have a report that we presented that we sent to the legislature on November 1st from Public Consulting Group, sort of thinking about provider rates and a regular way to update them, and one of the things that they wax poetic on is this exact thing. And some of the things that they recommended are surveys that are really, by the time you get them, pretty old. CAHPS is about 2 years behind. It's sort of our best measure of patient experience of care, and it's not great. They also use several other surveys that were all roughly 2 to 3 years old. And so it's really hard, I think, to improve access when you're looking at what happened 3 years ago. And at least I think for our agency, our world changes so much every year in terms of what we're doing. And so it's a really kind of a lagging indicator. So we're definitely looking at other ways that we can measure this, but it's a tough problem and an important one. Yeah.
Well, I know stuff. It's a very difficult problem. I mean, I tried to actually get my own organization when I was still there. I think it is a challenge, but I do think it's something that's really important to look at. The things that I've heard most recently in the Medicaid provider community, which is, I think, quite disturbing, is with the rapid increase in the number of adults on Medicaid, the number of specialists willing to take Medicaid patients actually is decreasing. They may be enrolled as Medicaid providers. The number of patients they're willing to take is really limited. And which I think is an interest, it's a challenge. So we get people enrolled, but we're not able to get the care they need. And so I think we need to really think creatively about how do we get some measures, even if they're gross and even if they're not perfect, we need to get some that allow us to know whether or not we're doing the right thing.
Yeah, and I absolutely agree with you, and I think it's particularly tough with specialist access because there isn't any way to measure other than sort of talking to providers. Does someone get in, or how long do they wait? Because I think waiting is important, but we are definitely, this is an area that the department's very concerned about and working on. So Project ECHO and our eConsult program, the eConsult program in Oklahoma had some great results in terms of decreasing wait time for specialists from like 3 months to 2 or 3 weeks, which I think is fabulous. So yeah, we hope to make some strides in that area because I agree we need to make sure that people can get the care that they need.
Great, good point. Other questions? Thank you very much and welcome.
Thank you.
Who's doing the department? I guess it's you.
Yeah, I have to follow Bulldog, that's not fair. Well,
department updates.
Department updates. My name is Tom Massey, and I serve as the Chief Operating Officer for the department. And first and foremost, thank you all for being here. Thank you for your service. We really appreciate everything you do, and this is a difficult job, particularly in this time of year, getting here. So again, thank you very much for being here and bearing with. This has been one of our longer meetings of recent memory. So I get to give you all the good news, though. That's kind of fun. One of the things that we have to report is the fact that we, as a state, were awarded a $65 million grant here since our last meeting for our SIM grant, which is our state innovation model. And for those of you that aren't familiar with it, I think most of you probably heard about it, but our SIM model is trying to create a coordinated and accountable system of providing access for integrating, behavioral and physical health, kind of a community health model. So it's got to be taken to scale statewide. So it's not just us; it's private insurance and Medicare and Medicaid and CHIP, but all the systems we're trying to find a way to integrate, again, physical and behavioral health. And our original ask was about $85 million. We were pared down by our friends at the feds to 65. So we're actually trying to chase another 20 through our friends at the foundations and various funders, philanthropic funders, to try to get back up to that level, because we think the model we built was particularly effective, especially that higher threshold. But irregardless, we'll do something very dynamic with, even if it stays at 65. So we're thrilled to get that. It's going to be implemented over the next 4 years. It's very broad-based. It's actually an initiative that's housed in the governor's office, and the lady's name is Vatsala Pathi, that is the SIM project director. She's from the governor's office, but we've got space for her in our office over at 225 as well, so she'll be working very closely with us as we are the lead administrator, so to speak, even though it is out of the governor's office. So. And I think Vatsala is actually going to come into the tri-agency meeting y'all are having on the 21st and give you an update on how we move forward with this. So I just got to make the announcement. She'll get into the nuts and bolts on your meeting on the 21st. So some of the new things we've seen, obviously the new legislative session just started on Wednesday. We have a new Speaker of the House, Dickie Lee Hullinghorst. She's a Democrat from Boulder. We have a new Senate president, that's Bill Cadman, a Republican from Colorado Springs. So we do have mixed houses now, which some of us that were familiar with the process think is probably a good idea. It gives us a nice balance. So we won't see anything too radical. If it doesn't make sense, it won't clear both either house. So hopefully it'll be a very what do I want to say, a very balanced approach now to legislation, maybe a pragmatic approach to seeing legislation. Speaking of which, we just finished on Monday, we had our SMART hearing. And SMART hearings are something that was legislated, about 4 or 5 years ago, where each department actually comes in and reports to the committees of record how you're doing implementing regulations, how you're implementing any statutory changes. You talk about your performance plan, your budget, your ledge agenda. Director Birch and some of the support staff, Gretchen was there. And by the way, we're thrilled to have Gretchen, and I want to acknowledge that. And at the same time Gretchen started, we also hired a new HR director, which we're thrilled to have. Our longtime HR director, who'd been with us about 30 years, finally retired. So we have a new lady named Joy Simpson, who's our new human resources director. And she came to us with a history from Department of Reg agencies, and recently she's been running all the driver's license offices. So Joey started on Monday too, so we're just plowing right ahead. So anyway, back to the SMART hearing. We feel like we're starting to get this system down, because we had a very good presentation, and we actually got feedback from Chairman McCann, who actually chairs one of the health committees, because we were actually in front of the three committees, the Senate Health Committee, and then the House has two committees, public insurance and private insurance, basically. And Representative McCann chairs the private insurance version of the committees, and came and told us it was far and away the best SMART presentation she'd ever seen. Very comprehensive, very to the point. So we're kind of proud of the fact that we're finally zeroing in on what our friends down the street are actually looking for. So that's kind of pleasing. But I will tell you, a lot of the discussion that we encountered down there was on provider rates, specialty care. How do we augment specialty care? And I think we have a commitment. I mean, it will remain to be seen, particularly on how the dollars continue to flow from recovery dollars that start coming into Colorado. If there's a real will to increase reimbursement rates to a significant enough place that we will start reaching some of the specialty providers. I mean, let's face it, one of the big concerns, if you've followed the news, is 27 states are now talking about the fact that they won't renew the primary care rate bump that we put in place a couple of years ago. And I saw that can cost some states anywhere from 42 to 47% of the rates that they're actually paying to primary care providers. You know, there's a lot of concern. Colorado, the good news is our governor and legislature was cognizant enough that we needed to keep those rates up to be able to attract providers and keep our access up, even with an increased Medicaid population. We're doing pretty well. We have increased our provider rolls every year by about 8.5%. But the fact is, we're going to, as long as we can afford to, we're going to keep that primary care rate bump and actually look for ways to augment it and even bring in more specialty care. So, that's the good news. The home modification rule that you passed a couple months ago, the first meeting on that is the 23rd of this month from 9:30 to 11:30. We'll fill you in on how that goes. We're excited that that's up. Our new Peak mobile app, which is our mobile phone application for provider access, keeping your info up to date. It has access to health information. It's not an enrollment tool, but it's actually a tool that augments how our folks can actually keep informed within our system. We've just started a soft launch with that. That will continue to evolve. We think it's going to be a very significant tool moving forward. So we're still, pleased that we're above 80% on our real-time eligibility enrollments. So things are going well. We're still partnering with Connect for Health Colorado. We announced our numbers at the end of last week, the enrollment numbers from the 15th of November through the end of December were Connect for Health Colorado had enrolled 113,864 folks, and we have found new Medicaid CHIP enrollees of 37,498. So it continues to grow. We have slowed down, which is probably a good thing. We're starting to find all those folks that we really wanted to bring in. Again, I argue with some of my more conservative friends down the street that the sooner we get these folks into the system, the sooner we take care of pent-up demand, and we do it with 100% federal dollars, which just makes sense for us. So things are going well in that regard. Coincidentally, I just got back from Texas late last night, and one of the lead headlines on the Houston Chronicle was The new governor-elect of Texas had just gotten a report that they had enjoined, and it says that Texas should actually expand Medicaid, and he's strongly considering it. Because I think they said they were going to leave over 10 years $67 billion of federal funds on the table. And I was actually staying with a couple friends out there that are both docs. I said, no, don't do it, because we'll continue to take your money. We're happy to do that. It just helps us. But I think that the sense of expansion and getting folks covered under primary care is really starting to resonate nationwide with all. And it was real interesting in our SMART hearing to even have discussions with our friends that might not have been favorable toward expansion a couple of years ago, are realizing the inevitability about the benefit of providing primary care coverage to everybody. What in the long term it'll do to bending the cost curve, to population health. I think they realize that now there's no sense in trying to back that down and moving away from expansion. It's how do we do it better? How do we make sure we have an adequate network, and how do we continue to fund providers? So it's going to be a lively and interesting discussion. So that's about all I have for new things. I will tell you our legislative agenda. We have a pretty pedestrian legislative agenda as compared to some of the things we've done in the past. It's not extremely robust because we feel like we want to steep some of the things that we've been doing, that we've done some pretty heavy lifts over the last few years. So at this point, we only have 2 actual department bills. One of those is to eliminate the waiting list on children with autism. Right now, we have at least identified a waiting list of about 320 potential kids that want those services. We're going to eliminate that wait list and provide age-appropriate services and continuation of services. And we've had very little resistance on that. I think a lot of bipartisan support, as a matter of fact. Our other bill is expanding the teen pregnancy and dropout prevention program that was originally piloted in 3 counties. Has been a great success, and I think, again, we have bipartisan support on that bill from both the House and the Senate, so I think we'll do well with that. Our budget ask, probably the biggest thing we have by way of a budget ask, is we've asked for a significant number of new FTE to augment our customer service center, making sure that our clients and people that need information don't have to wait an hour and then be hung up on and then call back again. So we really want to provide a much higher level of customer service and client satisfaction. So, and believe it or not, we've received very little pushback on that. I think everyone realizes the benefit. It makes all our lives better when we timely address the issues. We will probably do it more in a tiered system where we'll try to create different tiers of levels of expertise, where the very rudimentary questions go to the basic call center, and then we have subject matter experts that work on up the tiers where we can direct those difficult questions. Because this is some of the feedback we got from counties, that now that we're starting to deal with some more intricate issues, the average call waiting or average call length had gone from about 30 minutes to 45 minutes and beyond, just because they have more difficult issues to deal with. So we want to make sure we have adequate staff and ability to really provide top-notch customer service and client satisfaction. So that's our goal. We feel like we're on a very positive direction. We've made great hires, as witnessed by, again, Gretchen and the folks that we're bringing in. We're still a very lean operation. We're $8.6 billion budget with less than 4% admin costs. So that says a lot to, we're very proud of that. So with that, I'm happy to take any questions.
Yeah, Ms. Robbins.
Thank you, Mr. President. What is your expert opinion on how the nation is going to address curbing medical costs and pharmaceutical costs to help offset the cost of the Affordable Care Act?
Well, you're presuming I'm an expert in the first place, so there's an issue there. I'm afraid it can't be a national issue. I think as states, we're going to have to lead that.
And I'm wondering if this is, as states become more involved, if that pressure will actually affect a change.
Well, we think so. I mean, because basically our ACC model, for example, it has been such a huge success we get a lot of inquiry from other states saying, how do you do this? Let us model that. How do we work with you? As those things start to evolve across the nation, I think that will have a national effect. Some of the things that we have in the hopper long-range plans where we hope to do more by way of what we have to offer as a department could well work toward bending the cost curve. I think when health exchanges become really fully viable and competition can really work the way it's supposed to within the exchanges, I think that will help bring costs down. Again, the fact that we're already starting to see costs come down. You talk to our friends with the Hospital Association, and because of our hospital provider fee, which incidentally, our hospital provider fee has not been as much of a target of skepticism as some of the others nationally, because we're one of the few states that directs that hospital provider fee towards solely providing for expansion, whereas other states actually just roll the funds into their general fund budget. And there's some criticism of that, but ours has been pretty pure from that standpoint. But we're getting anecdotally that a lot of the hospitals are seeing their uncompensated care go down by about 40%. As that happens, we won't see the cost shift as much. Hopefully premiums will start. Even witnessed by the last issue of new premium on the exchange. On average, it was 1%. That's not true for every region, obviously, for regional differences, but on average, statewide, it was about 1% increase. We haven't seen numbers like that in years, so hopefully this is a sign of the times that we're on the right trajectory.
Thank you.
You're welcome.
Other questions? Great, thank you very much for those updates.
Thank you. Mike told me he was going to cut me off by 3 o'clock, so I made my limit.
Yes. Well, two other quick things. One, Tim, do we still have you on the phone?
I am here.
This is Tim's last meeting with Medical Services Board, so we want to thank you very much for all your contributions to the board, and you'll be missed.
I just wanted to say, and I really wanted to do this in person, but life events intervened. What a pleasure it's been for me to serve on this board over the last year and a half. The group of folks, both at the department and on the board, are really a remarkable group, and it's been such an honor for me to work with them, and so I wish you all the best of luck.
We appreciate that and hope our paths cross again. And then the last thing I have on the agenda, I think we all have a handout for the meeting we're going to have on January 21st with the 3 departments all coming together. So hopefully everyone can get that on their calendars and spend those hours together, because I think it will be very beneficial for all the boards as well as the state for us to kind of have some time to talk over some issues together. So have that, and if we need any arrangements, Judy's here to help us.
Yep.
Anything else for the board? Otherwise, we do have some sandwiches here, but
And there are some paper
adjourn.
bags and stuff, so if you want to take them with you, or I wanted to tell you.
All of you enjoy your weekend.
Well, legislature.
Yeah, go Broncos.
Yeah. Good job, Sean. Thanks. See you later.